I declare open this public hearing being held at the Mantra on Russell of the House Standing Committee on Health, Aged Care and Sport for the inquiry into the health impacts of alcohol and other drugs in Australia. In accordance with the committee's resolution of the 4th of August 2022, this hearing will be broadcast on the Parliament's website, and the proof and official transcripts of the proceedings will be published on the Parliament's website. I wish to acknowledge the traditional custodians on whose land we meet and pay my respects to the elders past, present and emerging of all Australia's Indigenous peoples. I welcome the witnesses from the Centre for Alcohol Policy Research at La Trobe University to give evidence today. For the Hansard record, before giving evidence, could you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a short opening statement before we proceed to discussion, and thank you very much for appearing today.
Thank you. My name is Robin Room. I'm a professor at the Centre for Alcohol Policy Research at La Trobe University. Next to me is my boss, Emmanuel Kunche, who's the head of Centre for Alcohol Policy Research. I've worked on, I'm a sociologist who's was born and grew up in Australia, but spent a good deal of my life working elsewhere on alcohol research in the US and Canada and Sweden besides Australia. What I'm going to talk to you today about is some ideas in reducing the burden of alcohol consumption on health and welfare in an Australian environment. Alcohol is among the top 10 factors for disease and loss of life globally, according to the best calculations, and Australia is above the mean consumption level among wealthier nations. Australia has an eventful history of thinking and action on alcohol, strong temperance movements in the early in the 20th century, generational reactions against restrictions later in the century, and relaxation of the restrictions in our neoliberal age, so that the numbers of licenses for selling alcohol have gone up a great deal. During COVID, Australian governments primarily acted on the assumption that alcohol was an essential part of daily life, which should be deliverable. So Australia was among the minority of nations where per capita alcohol drinking rose with COVID. On the sheet that I prepared, I've got a copy of a map of the world from a World Health Organization World Health Organization publication. Unfortunately, didn't reproduce very well on my home copier. So we were among the minority of nations where per capita alcohol drinking rose with COVID rather than falling by more than 0.1 litres from 2019 to 2020. In the new world of texting, where everyone lives and walks on their phone, alcohol could be ordered to be delivered from home, from on-premise as well as off-premise outlets. Delivery by agents which are not subject to alcohol licensing, the delivery agents. And originally this was a temporary arrangement that was set up during COVID, but in Victoria and I think in some other places it's been made permanent. So that COVID has actually, resulted in a substantial increase in the ease with which Australians can order and have alcohol delivered at home. WHO has put out in the last 10 years or so some documents which talk about best buys in healthful alcohol policies, what governments need to put in place to limit the harm that comes from alcohol. One of them is raising taxes, which is a federal government responsibility in Australia, as you know better than I. And the thing that is most notable in the Australian tax regime for alcohol is that wine is taxed by value and not by alcohol content like the other alcoholic beverages, which means that some wine is available as the cheapest alcohol in bag-and-box arrangements and so forth. This has led in the Northern Territory, which has no power to tax alcohol itself, to adopt a minimum alcohol price law to try to undo some of the problems from the federal legislation on taxation. So the first of the best buys is raising taxes. The second is controlling marketing, advertising and promotions. This is mostly a federal responsibility in Australia, but some state and local opportunities, for instance, on public transport or in parks that are owned locally or by the state, the controls are limited, mostly that there exist. They're mostly by time and mostly for TV and radio, so that there's very little Australian legislation governing the specifically governing the promotion of sales of alcohol. The third of the WHO's best buys is controlling availability, which has to do with the number of licenses and the opening times and so forth. That, of course, has changed considerably with the advent of electronic ordering and delivery. Mostly states and territories have this control rather than the federal government through liquor licensing arrangements. They've been substantially weakened in recent decades and undercut by web and phone ordering and delivery and by the weak enforcement of the system. So our recommendations are, first of all, with respect to taxes, that they should be based on alcohol content and equalized between beverage types, so that the level is at least as high as the current tax on spirits. And the recurrent revision in the light of inflation, which Australia already has, should be kept. Advertising and other marketing, the TV, radio and web advertising and promotion should be federally prohibited. Alcoholic beverage promotion, which is not allowed in, should not be allowed in sports events and during daytime, that's 6 a.m. to 9 p.m. And alcohol advertising should be prohibited on public property, including public transport vehicles, stops, and other installations. On the matter of retail licensing, the numbers should be limited overall and by neighbourhood. On-premise licenses should not include off-premise delivery, and off-premise deliveries should be separately licensed. Deliveries only 2 or more hours after the order and not to the intoxicated. And the off-premise delivery person should be acting under the alcohol licensing laws, which is not true now.
Good.
Thank you.
Thank you very much. We'll now proceed to questions, and I might, before we do that, get the members of the committee to introduce themselves.
Anne Stanley, I'm the Federal Member for Werriwa in South West Sydney. Anne Stanley, I'm the Federal Member for Werriwa.
Thank you very much.
Yeah, Mike Freelander, Chair of the Committee, Member for Macarthur, also in South West Sydney.
Thank you.
Michelle Anandaraj, Member for Higgins in Melbourne.
Julian Lisa, I'm the Member for Barara in Northern Sydney, and I'm the Deputy Chair of the Committee.
Monique Ryan, I'm the Member for Kooyong in Eastern Melbourne.
Yeah, we might start with Mr. Lisa. Questions?
I had a few questions. Can you tell me at the moment, in relation to the regulation of alcohol advertising, what are the restrictions that are currently placed on alcohol advertising in terms of time on television? You propose that there be nothing between 8 a.m. and 9 p.m. What's the current level of restrictions?
I think there's rather few restrictions, in fact, they mostly have to do with around not advertising actually during the sport. But even then, you know, you look down on the the sports arena and there's all the advertising around the edge that shows up on the television.
But I mean, there must be advertising restrictions around children's television programming, for instance. And I just want to know to what extent is what you're proposing a radical departure from what exists now, and to what extent is
It's a substantial departure from what is true now, but it's not a radical. You know, there are some restrictions now. Yeah.
Do you have any information for us on what are the current restrictions in relation to liquor licensing in geographic areas? Are there mandated legislative restrictions at a state or territory level in relation to, you can only have one grog shop within a particular area, or they can only have a certain number of limited licence premises in a particular area? Is there?
It's highly variable. It varies with state legislation, and for that matter, in terms of place. There still, until recently, were several places in Victoria where no licences were allowed in that particular area. Which is left over from long ago.
What sort of places were they? Were they regional areas, or were they?
They were areas that had voted not to, where the local people had voted not to have licences, essentially. But they'd done that voting about 100 years ago. So,
Can you give us an example of one of those areas?
Excuse me?
Can you give us an example of one of those areas?
Camberwell,
Really?
which is in my electorate. Yes.
Yeah.
Interesting.
Yeah.
Been tried for a long
Yeah. Now, my understanding is that they're in that is in the process of being discontinued. Is that right?
That's right. But there's no wine bars but no pubs.
Yeah.
It's anomalous.
The third question I had was in relation to your point about online ordering. I assume you're making a distinction between people's ability to, say, order a case of wine, which you've been able to do for delivery for many, many years to your home, and what occurred during COVID, where people could order effectively cocktails and so on to be delivered to their home from.
Yeah. Well, what happened during COVID, and it varies from one jurisdiction to another, one state and territory to another. But what happened during COVID was that on-premise restaurants, in other words, were allowed to deliver alcohol along with the meal that they were sending home, essentially, and which was a big, considerable change. Most home delivery prior to COVID was of people ordering from Laithwaites and these other companies that advertise. And those deliveries happen after a week or something. They're not immediate. What we've got now is a situation where you're having a party and you run out of alcohol and you can call up and have some delivered almost immediately.
Have you got any data on the prevalence of the continuation of delivery in those sets of circumstances post-COVID?
There's not a huge amount of data on post-COVID. During COVID, our office did a couple of studies. They're fairly small studies, but we were, interviewing people who had ordered alcohol. Quite a few of them were quite heavy drinkers. Quite a few of them had ordered in connection, in the middle of parties and so forth. But that's, a relatively small study, and there aren't really big studies of it. Yeah.
I suppose the question is, I understand what you're trying to get at here is that you don't want people who are intoxicated or addicted to be able to order alcohol to their.
Yeah, and
how do you balance that with the reasonable ability of people to order alcohol for the purpose of putting on a party, or that they do run out of they've ordered too few beers or too little wine or what have you.
If you're willing to have it delivered a week from now, then I don't think there should be a particular limit on it. I don't mean literally a week, but I mean that it's not an immediate decision that is then carried out.
Nothing further from me, Chair.
Good. Michelle.
Thank you. The COVID spike in drinking that you talk about, I saw when I was practicing as a clinician
Yes.
at the Alfred. I saw a lot of young men in their 40s, professionals, who presented bright yellow, basically with acute alcoholic hepatitis. In a couple of occasions, it was linked to domestic violence. It was certainly linked to job loss as well as bereavement and divorce. So, and that was really the first time I'd ever seen that in my whole career, that acuity, and particularly in young men. My question relates to, I guess, controls, similar to Mr. Leese's line of questioning. I think alcohol is far too available, and this online ordering of alcohol, I think, is a problem. It's highly problematic because it seems to skirt the guardrails that we have currently in place. Identification, for example, level of inebriation, et cetera, But I'm a little bit circumspect about raising taxes on alcohol, only because it's such a highly addictive substance, and people who are addicted to it will seek it out any which way. And I'm worried about untoward effects like moonshine, methanol. We've seen with tobacco excise that really we're reaching a point where it's driven a black market, and it doesn't seem to be doing what it needs to be doing at a public health level. So can you perhaps comment about raising taxes on alcohol? Can you comment about raising taxes on alcohol and whether it might actually drive more, untoward effects?
Yeah. You can raise taxes high enough that you start getting the negative effects you're talking about. I don't think that Australia's in danger of doing that at this point. And it's also depends partly on the circumstances in the country. It's also true that tobacco is more easily transported than alcohol. I think the WHO suggests for taxes on tobacco that it could make up as much as I think is it 85%? I can't remember of what the rest of the price would be. It proposes some specific amount. It doesn't do that for alcohol, and I think it's a mistake that it doesn't. But I think that Australia could well aim to considerably raise its taxes without any danger of increasing.
Are there countries, are there examples of countries that have raised taxes above Australia where it's actually led to a population-wide reduction in alcohol consumption?
Yes, there are.
Which countries? Peer countries?
Well, a good example is Lithuania, you can actually see it in Russia. Its consumption goes like this, and the second time around.
Russia's not a peer country, though. Are there any countries that we would regard as peer countries?
Well, the Baltic states like Lithuania, the Nordic countries do, have a substantial history of limiting the accessibility or the availability of alcohol with government monopolies and so forth, as well as with price. That's one of the mechanisms. That comes out of a history of them having quite a heavy drinking culture, if you look back a century, essentially. I don't know. It depends what you look at in terms of what countries are like Australia, but certainly Canada is another country which has a fairly tight consumption.
And do they have a lower consumption than us per capita?
Yeah, I think it's a bit lower.
It is a bit lower,
yeah.
Right. Just another question regarding major sporting events. There does seem to be a spike in domestic violence after major sporting events, and it's clearly linked to alcohol. Alcohol is absolutely in play there. What proposals would you suggest could be put in place, public health sort of messaging or prior to these events, which are obviously major cultural fixtures in our country?
Well, the problem that we have in Australia is that, we're a country that very much appreciates its sports. And there's been a very clear decision, to by a number of sports types of sports and by the alcohol industry to work together. And that, I think, is problematic, essentially. And so that you get the the framing of some kinds of sports primarily in terms of, it being a drinking occasion, essentially, for the spectators. I think that needs to be worked on several different levels, but part of it is with legislation that controls how much a sporting event can get in the way of resources from the alcohol industry, essentially.
Have you got any thoughts on what sort of public health measures or levers we could use in a run-up to one of these events, like a grand final and so on?
Well, I think the limiting the alcohol advertising and promotion in connection with the event is one thing to do. I think limiting the availability of alcohol actually in the event, putting some sorts of limits on it. Those would be immediate things to think about.
Yeah. Okay. Thank you.
Yeah.
Monique?
Thank you. Thank you both for your time this morning. Are you able to give us any insight into the extent to which minors may have accessed alcohol, in the ways that you've mentioned, for example, during COVID and the online ordering of alcohol?
Yeah. Well, you get down, there's some studies by people in, headquartered in South Australia of teenagers and their parents and how they interact with each other around alcohol, and it's certainly, there's a lot of variation among Australian parents in their attitudes towards underage drinking, and to whether they should be the instruments through which the children can get alcohol. And there has been very little, there's been rather little discussion of that in public. But, if you go and ask 16-year-olds where they get their alcohol, then it's from relatives, and parents and so forth, that is the primary source of alcohol for them.
Okay, so it's in terms of, are they able to order it online though? I mean, are there checks and balances in place that are working?
Yeah, there are checks and balances in play. There are checks, the line.
I know they're there, but are they effective?
They'll tell you they're there.
Yeah.
The extent to which they're enforced is really unclear, essentially.
Okay. And would I be, thank you, and would I be right in assuming that limits that you would like to see on alcohol advertising would extend to social media platforms?
Would
Extend to social media platforms?
Yes,
many of
absolutely.
which
Yeah.
alcohol is very aggressively marketed to young people?
Absolutely. Yes, I think that actually the advertising on social media is not well controlled. Yeah.
No.
Sorry, I'll jump in. There's also the problem about, that blurred line between influencers and marketing, and it's not often clear what qualifies as marketing and what qualifies, where are the boundaries. So that's really difficult to control, but of course it's worrisome.
So there are influencers, for instance, who are paid, for their influencing, essentially, and but they don't count as being officially advertising.
No. And I'm not sure, I don't think this committee has, but certainly other parliamentary groups have seen lots of evidence about the very profound effect of influencers and social media advertising and design of algorithms to particularly affect young people with their purchasing of alcohol. Are you aware of evidence regarding the differential effect of things when young people see it online as opposed to when they see advertising around the edges of the MCG during a footy game or whatever?
We have a colleague who's working in that, but it's not very well studied, I think, at this point. That's my impression.
No, and especially online, you can do so much better targeted advertisements. It looks so much better than it would look in real world, right? For example, there are celebrities and they have their own brands of alcohol, and they can, propose that online in a glamorous environment to a lot of people, very targeted.
I guess I think that's my point, actually, that it may well be a good idea to ban advertising around the edges of a sporting ground and the like, but I think that for young people, the things which are probably most influential are what they're seeing online, which is obviously very aggressively marketed towards them, but also, as you're saying, sometimes very sophisticated, the way in which that's happened. Thanks, Chair.
Good. Anne.
I'm interested about the answer that you gave to Mr. Lisa about the statistics that are available for online immediate delivery, because to regulate that, we need to know what we're regulating, like what is the problem? I realise we all agree that this is a problem, but if you're going to make legislation, you need to make sure that it's going to make a difference. There's no point in saying, oh, well, we'll just ban it all, because there's lots of money behind these things. They will find a way around it. So I'm interested in teasing out whether people are currently doing this sort of work about the relationship between quick delivery and harm, and because there will be an argument by some people that adults should have the opportunity to do this. I'm really quite concerned, even when you buy alcohol online, really the only question you have to answer is, yes, I'm 18. It's just, even if it takes a week to get to you, the only question is, yes, I'm telling you I'm 18. Yeah. Which, a 2-year-old can answer yes to that question. Yeah. Clearly, a 2-year-old's not having alcohol, but that is no barrier either. I'm not sure there's a great difference between getting it over a week or getting it in an hour to the harm that it can do.
Yeah.
Yes and no. If someone is already slightly inebriated, and there are people in the household, that person probably should not get completely intoxicated. And then the time frame would matter, if that person would get in an hour more alcohol. But in general, I agree. I would also add that often, apart from that click, are you 18, there is no real gateway to the ordering, but also to the receiving end. Often you have the possibility, leave that at your doorstep, and then anyone can pick that up in the household or otherwise. So there could be better controls on both ends, right, on the receiving end and on the ordering end.
I'm not so sure about that personally, but how are you going to police that? You say, speaking of the delivery person is going to be doing a sobriety test?
No. You can leave it at the doorstep, and then people can pick it up. So there should actually be a signage, and someone, you could check an ID when the receiving part occurs.
And the current situation is that delivery person is not employed by the alcohol store. They're employed by the delivery company, or self-employed, and they're not under the control, in other words, of the licensing laws. Sure. So that there's no way, there's no governmental provision for them that they need to worry about in terms of how they behave at the doorstep.
Sure. Yeah, no, I get that, but hard to police. Any more questions?
No, thank you.
Can I just, I want to follow up from Ms. Stanley's question. Firstly, I just want to put a proposition to you. In some respects, is having alcohol delivered to people, even accepting what you say about the fact that it leads to greater intoxication, is it not to some extent a benefit, because the alternative is if somebody wants to go out and get alcohol, there's the danger they might get behind the wheel of a car when they're inebriated to go and buy more alcohol, and aren't we actually perversely preventing alcohol-related car accidents by having more delivery at home? I just want to test that as a proposition, and then I've got one more question on it.
Yeah. No, I mean, absolutely. I mean, I think the crucial thing to keep in mind is that, alcohol is an extremely dangerous product. In terms of the number of folk that are killed or injured or lose time from work or whatever it is around their drinking, essentially, or someone else's drinking that has affected them. And Australia certainly showed the world and showed itself that it could do something about that with respect to drink driving, because there certainly is, a substantial Australian history of legislation and continuing improvement of the laws around drink driving, essentially. And they are effective, essentially. But we haven't done it for anything else with respect to alcohol, and particularly, one of our colleagues, one part of our office, is concerned with testing the amount of harm to others that comes from drinking, not just the harm to the drinker or the costs to the government of looking after the drinker. And that essentially doubles the cost of alcohol, to add in those costs to other people around the drinker, essentially. So that this is a substance which is, yes, it may carry benefits for the drinker. It may carry adverse effects for the drinker, but it's not only the drinker who is at stake with respect to that alcohol.
Certainly see that in the paediatric field, for sure.
My second question relates to the responsible service of alcohol, and to what extent that is policed. It seems to me that there's a lack of enforcement of the laws in relation to responsible service of alcohol, whether that's, particularly in a retail environment of people who are being served who are clearly intoxicated.
Yeah.
Do you have
I think I agree with you.
Do you have anything that can assist us in that area in terms of?
Well, there is some good research in the US, essentially, of what happens when you increase the enforcement of those kind of provisions. And, the rates of alcohol harm go down. There's no question about that. But I agree with you that the, Australian states and territories do not put a lot of energy into that enforcement.
Is there any Australian data on this that you can, perhaps, you might want to take this on notice, is there any Australian data on this that you can help us with that demonstrates that what happens when enforcement of the responsible service?
Well, it'd be interesting, some of the Northern Territory studies of what happened when they changed the provisions in the Northern Territory would be relevant for that. I think there are some things that we could point out to you, essentially.
That would be helpful.
Take that on notice and send it to us, that'd be good. I want to explore that a little bit more, if I may. Can you give us any data about the costs of alcohol abuse in Australia and whether those costs are diminishing or are they getting greater? You may not have that data here.
We have an economist working with us,
Yeah, so the costs of to alcohol to Australian society is $183 million each day.
Each day?
Each day the Australian society costs $183 million. That is more than sevenfold what the tax income is. So for $1 that you gain on taxes, you spend $7.5 on harm. That is also about 8 times what the harm of all illegal drugs together is. So it's Yeah, and one of the big problems here is that the majority of these costs of the 183 million a day are not produced by alcohol-dependent or excessive drinking people, but they are produced by the large majority of drinkers. About 2/3 of the drinkers drink relatively moderately. Now, the problem is that moderate alcohol consumption already generates a lot of these harms. In terms of injuries, accidents, and cancer, each drink is harmful. You have already an increased risk. I think it's twofold, even at the legal driving age limit, so the 0.5%. You have already the double of injury risk. Even driving
Even
in the limits.
0.05 doubles your risk of injury.
Yes, yeah. And also cancer risk increases from the first drink onwards. So to decrease these enormous costs to the Australian society, it's a good idea to decrease per capita consumption, any kind of alcohol drinking. If you would lower the total volume consumed, that would have an enormous gain to the society.
Yeah.
And how you do that, what Robin already mentioned, is the best buys of the WHO. You know, they recommend what are the best policies, which is basically making alcohol less affordable, less available, and less attractive.
And your suggestions are volumetric pricing? Volumetric alcohol
Yes.
pricing
Yes, yeah, and a minimum price as well.
and minimum price?
Yeah, in terms of affordability. And closing that loophole, so to speak, of cask wine that is not taxed volumetric, but based on value. Making alcohol less available, any measure to make it less available is a good measure in terms of public health, and that comes to online delivery, that comes to outlet densities, opening hours, licensing, and so
I
on.
want to talk to you about that and go back to the temperance movement. Was there evidence of success?
Well, yes, in some ways. I mean, the US banned alcohol from 1919 or so till 1933. At the beginning of the ban on alcohol, the consumption of alcohol fell by 2/3 in the US, by the best estimates.
Were there
Even
demonstrable
by the
health benefits of that?
Sorry?
Were there demonstrable benefits of that?
Yes, absolutely. Even
Can you
by
give us
the,
any data on that, though?
Yeah, there's substantial studies of it. Yes, and
Could you
at
take
the
that on
at-
notice?
Sorry,
Could you take that on notice?
could sending that to you?
Yeah.
Yeah, sure. The classic line on it is essentially at the beginning of Prohibition in the U.S., consumption fell to 1/3 of what it had been before then. By the end of Prohibition, with reaction against it and so forth, it had risen to about 2/3 of what it had been, but it was still lower than it had been before Prohibition, essentially.
Okay. And this has relevance to my electorate. We have new suburbs appearing all the time in my electorate. It's the fastest growing electorate in Australia.
Yeah.
We have local people who don't want a new hotel, a new
Yes.
bottle shop in their new suburb,
Right.
but are powerless to stop it because of the planning laws.
Yeah, well, I mean, this depends on the state or territory's laws about
Sure.
that. But essentially, people who want to make some money on it are going to put a lot of energy into arguing for the license, essentially, and the local community people opposing it are
Powerless.
not likely not to be listened to.
Do you think we should change our planning laws?
Sorry?
Do you think we should change our planning laws?
Yes, I think that the what's happened and this varies a bit from state to state, but the general tendency has been to reduce the ability of a local community to argue against a new license, people in the local community to argue against a new license. And so you can find some, very clear cases of where they've come and complained and so
Yeah.
forth, and it's had no effect.
Yeah.
I think part of the problem is that the proof is on the community, right?
Yes.
So the community has to prove the harm. It's not that the alcohol retailer has to prove the
Exactly.
non-harm. So this is part of the problem. And it's very difficult to provide sufficient evidence of the causal effect of the harm.
Well, I think it's quite amusing. You walk to any hotel in any major capital city, see the vomit stains on the footpath to show you how well the laws are being enforced about responsible service of alcohol.
Well, I know more about Victoria than other states, but the licensing procedures have been changed over the years so that the local community has less power to oppose a new license.
Yeah. Now, the other suggestion has been made that we should be making the purveyors of alcohol responsible for the health effects, so that if there are changes to the taxation system, it should be at a corporate level rather than at a individual level. Have you looked at that at all?
I didn't quite understand, I'm sorry.
Well, instead of taxation on
Yeah.
consumption,
Yes,
we should be taxing the corporations that are purveying alcohol
Yes.
according to the community harm they're causing.
yeah. Well, I think one argument is that there's all this cost associated with it and that is not being covered by the taxes that are collected on alcohol at this point. Far from being covered by it.
But the problem is on the consumer as well. You put your health on danger, and it is to disencourage people from consumption for their own good.
Yeah.
So therefore, it makes sense to tax the product, because this is what produced the harm to the consumer, not only to the society. So the idea is to make it just less attractive, less available, less attractive, less affordable. Whatever measure contributes to that is a good measure.
Yeah. Good. Sure. Just one last question. There has been a little bit of evidence about young people's alcohol consumption actually going down.
Yeah.
Do you have evidence for that? And are we seeing less harm because of that?
There is evidence that young people are telling survey people that they're drinking less, and I think it's actually truthful. I think there's some evidence that it is reducing harm for young people. The opposite has been happening in recent years among middle-aged women who used to drink a whole lot less than middle-aged men, but are beginning to catch up. And that is, an area that should be paid attention to, I think.
Good.
Some of the problems about that use decline is these health benefits we will see in 20, 30 years when there will be less cancers. And also in terms of injuries, it's very difficult to measure because the lower risk of injury that you have sometimes does not show up in statistics. Because it's just, you fell down the stairs, you break your arm, but
Sure.
that's not covered by the statistics. That was an alcohol
Well, that data is not collected.
so it's a bit difficult to measure. Some of the harms actually went up.
Right.
So there's no one-to-one relationship to reducing the consumption now and having the immediate benefits of it.
Sure.
These benefits will come later.
Thank you. Michelle?
I understand in 2020 there was abolition of a ministerial oversight body, the Drug and Alcohol Forum at ministerial level. Are you familiar with that body at all? Because we heard some testimony yesterday that this body was actually very important for coordinating whole of country response in the Federation, and it was abolished. And then we saw this uplift in online sales, and we've seen a whole range of harms as a result.
I think there's there's not enough connection at this point between the research findings that are coming out and the political process. And I think that that was an example of breaking the possibilities of those connections being improved, essentially.
Do you think it would be useful to have a coordinating body
Yes,
at the Commonwealth level?
It is useful to have a coordinating level, a body at a federal level. Also, actually, would be interesting. It would be useful to have better coordination within states and within a particular state and territory as well. That's not well coordinated.
And is there any, again, OECD country that has does not have online sales of alcohol?
Is there a country? Is that what you're asking? I believe there are a number of countries in the world, or states or other parts of countries, that have government monopolies on the off-premise sales of alcohol. That is, not around serving it in a pub, but around selling it to take away, essentially. And I believe that those countries like Norway and so forth would not allow the kind of web ordering and so forth, essentially. There, you can find examples of it. The advantage of a government monopoly is that it does mean that a lot of things are coordinated in the alcohol policy. There are a lot less stores than in a private market.
I don't think we're going to get a government monopoly up in this country.
Yeah, okay.
But I guess I'm just more interested in whether there are countries that actually don't have online sales of alcohol.
Well, I'm not sure of, I don't know beyond that. And how they would enforce it is the next question also. I mean, Australia has the, well, it's very interesting to look at gambling from that point of view, because the interesting thing about gambling that's different from something like alcohol is that you don't have to deliver some sort of product across the border. And so Australia has tried to ban the online sale of gambling, and it puts, the Australian government puts out a weekly bulletin or whatever telling the people who are providing the connections what are the new places they shouldn't be allowing to sell gambling in Australia. It's not 100% effective, but it is a substantial effort by the Australian government to cut down the online sales across borders, essentially.
Well, I might get into trouble if we go there. So,
Sorry?
we might get into trouble if we go further with the gambling analogy. So,
Okay.
Any further questions? No?
We've been looking at it recently. There is quite a substantial connection between gambling and drinking, and it's no accident that casinos
Serve lots of alcohol.
hand out a lot of alcohol, essentially.
So, do you see it as a public health issue? Do you see it as a public health issue?
Yeah, I mean, the gambling is a threat to public health, essentially. I mean, not only for the gambler, but for the gambler's family. There are negative effects, essentially.
Good. Well, thank you very much for coming today. And thank you for your evidence today. If you've been asked to provide any additional information, please forward it to the Secretariat by no later than Tuesday the 12th of November 2024. You'll be sent a transcript of your evidence and will have an opportunity to request any corrections to transcription errors. And once again, thank you very much for coming along today. It's been very interesting. Thank you.
Thank you for your attention. And question.
Good. So, we now call Turning Point from Eastern Health and Monash Addiction Research Centre to give evidence today. Morning. I now call Turning Point from the Eastern Health and the Monash Addiction Research Centre to give evidence today, and I welcome you. For the Hansard record, before giving evidence, would you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. Giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a short opening statement before we proceed to discussion.
Thank you. And thanks to the committee for inviting us to speak today on this really important national issue. My name is Professor Dan Ludman. I'm the Executive Clinical Director at Turning Point, Director of the Monash Addiction Research Centre at Monash University. And it's a pleasure to speak today. With me is Ben Vanica, who's head of our lived experience and peer workforce at Turning Point, and will be is critically here to talk about the experience of lived experience in this space and what he sees in terms of families and consumers in terms of navigating the system that we have in place today. I'd like to start by acknowledging the traditional custodians of the land on which we're meeting and pay respects to elders past and present. I extend that respect to any Aboriginal and Torres Strait Islander people with us today. I would also like to acknowledge the individual and collective expertise of those with lived experience of addiction, as well as the peer workforce whose expertise, partnership and experiences help us shape services that are safe, accessible and inclusive. Everyone knows someone who is struggling with alcohol or drug use because 1 in 4 Australians will. They're our friends, family and colleagues. But roughly 500,000 people aren't accessing the treatment, care and support they need, with individuals not knowing where to go for help and families not knowing how to support their loved ones. That's largely because addiction is one of the most stigmatised health conditions in the world. People internalise stigma and shame, which causes them to hide their use and delay help seeking. For example, the median time to first treatment for alcohol use disorder is a highly concerning 18 years. The stereotypes and negative attitudes others hold about addiction can lead to mistreatment and discrimination, and families experience stigma by association. Some communities also experience multiple forms of stigma and discrimination, which further limits access to care. And structural stigma compounds these issues with rules, policies and practices that constrain the opportunities and resources for evidence-based addiction policy, treatment. Many alcohol and other drug-related deaths are preventable, but we could be doing more. Tobacco, alcohol and illicit drug use collectively account for 15.4% of the total disease burden in Australia and are major risk factors for suicide and self-harm. More than 1,700 lives were lost to alcohol-induced death in 2022, the highest in a decade. Alcohol use is associated with a broad range of community harms, including family violence and a leading cause of fatal road crashes. We need to adopt evidence-based measures known to prevent and minimise alcohol harms, such as strengthening restrictions on alcohol availability, making treatment more accessible, and resourcing the national principles for school alcohol and drug education to ensure the widespread adoption and prevention activities for our children. As a frontline service at Turning Point, we see firsthand how the system isn't meeting people's needs. People and families are often left on their own to navigate a complex system that even clinicians struggle to connect with. This leads to a lack of continuity of care and the inability to offer more intensive forms of treatment. Everyone deserves equitable access to treatment, care and support. But because of service fragmentation, getting support can feel chaotic and is especially difficult in rural and regional areas. Investing in digital health solutions similar to other areas of health can help overcome access barriers such as stigma and geography, promote timely help seeking and improve system navigation and aftercare support. Delays in help seeking underpin increasing alcohol and other drug harms and treatment demand, adding pressure to an already stretched health system and budget. In 2021 to 22, there were over 188,000 hospitalisations where an alcohol-related diagnosis was recorded. A recent report found the annual cost to the Australian community is $80 billion and as much as $174 billion in the value of lives lost when considering their potential contributions in the future. We know that treatment works, but unfortunately the community doesn't. The lack of community awareness campaigns that tackle stigma and promote help seeking means many people don't know that treatment works or where to go for support. And limited exposure to addiction training across our health disciplines means even most health professionals feel uncertain in how best to respond. Total alcohol and other drug investment by all Australian jurisdictions remains in balance across the 3 pillars of the National Drug Strategy, with 64% spent on law enforcement compared to only 36% invested in treatment prevention and harm reduction. This is despite the fact that every dollar invested in treatment saves over $20. We should invest in solutions that work and adopt a whole-of-health response to addiction through a greater investment in prevention, treatment and harm reduction. We also need to invest in a range of research and data initiatives to improve service system planning and treatment outcomes, and update the National Alcohol and Other Drug Workforce Strategy to support the health workforce delivered now and into the future. My colleague Ben Vanica manages our peer workforce at Turning Point and can speak to the importance of lived experience perspectives. This inquiry presents an opportunity to rethink how we respond to alcohol and other drug harms and ensure a more coordinated national response to this urgent and growing problem. We can transform the lives of people experiencing alcohol and other drug harms, ensure access to effective evidence-based treatment and support, improve treatment outcomes and service planning, and unlock a community dividend that benefits all Australians. These are ambitious goals, but we can achieve them by returning to more inclusive national governance arrangements, developing effective strategies and implementation plans, and prioritising joint investment mechanisms. Thank you.
Thank you. I might get my committee members to introduce themselves, starting from Dr. Ryan.
Good morning. I'm Monique Ryan. I'm the federal member for Keong, which is in Melbourne.
Thank you.
I'm Julian Leeser, I'm the Deputy Chair and I'm the member for Barara in Northern Sydney.
Michelle Anandaraja, member for Higgins in Melbourne.
Mike Freelander, Chair of the Committee from Macarthur in South West Sydney.
And Stanley, member for Werriwa, and I'm also in South West Sydney.
We might start with Ms Stanley.
Sure. I've got two different questions. The first one, you've teased out how difficult, alcohol is and so forth. But alcohol is a legal substance. And I know we've heard this 18-year figure before people get the treatment they need. Do you think that some of that is because there is a misdirection about, because it's legal, because you can go and buy it, that it's okay, that it doesn't cause the harm? So there is a disconnect between people who are being badly affected in what they believe they're doing is okay and what is actually happening. Because quite often you don't get addicted necessarily in a short period of time. It's the length of time that you've drunk to excess, continued on, that's where the relationships go.
I might throw to Ben.
Yeah, absolutely. I think that the messaging is not out there in terms of the harms with alcohol use. I know for me growing up, watching alcohol just be a part of normal day-to-day life. So, I had my first drink at 13, and I'm talking a proper drink, not stealing one of Dad's beers and having a little sip. But when I grew up in regional Victoria, that was almost seen as once you hit your teenage years, that's when you start drinking. But there was I didn't understand the impact that alcohol would have on me as a young boy growing up. And then it became part of our rituals around the weekends where you'd play sport as a kid, and then in the afternoon you'd go drink with your mates at someone's property or whatever it might be. And there was no appreciation or understanding for the impacts that alcohol has on brain function, the physical impacts it has. And I look at kids, my nieces and nephews, and even my own children, and think, well, I was 13 when I started drinking, and it's quite frightening to look at them at that age now and see the harm that it could potentially have. And I have no doubt that the way that I drank as a teenager, and then it became, as you said, it progresses, and from 23 to 33 to be drinking every day for 10 years. I think the early days of drinking has had a significant impact on my cognitive functioning, and I'm forgetful, I have trouble with recall, which then has an impact on the way that I present in the community, has an impact on the way I present within my place of employment. But none of that was spoken to or even made aware as a young fella growing up. I knew that drugs were bad, that message was clear, but I never had that association that alcohol is a drug. and alcohol is just as bad. So I think, yes, spot on, there's a massive gap there.
Do you think that your nieces and nephews and your own children have a different understanding of how alcohol is presented, or have we not still provided that message?
I think my nieces and nephews do, because they know about my journey, and we're very transparent with them about the impacts that alcohol has had on my life, and people that we know. And my children are aware of that as well, and they're quite young. But I think broader, I think we're still missing the gap there.
Okay. The other question I have, we've heard about, since COVID, that online providers are able to, you can ring and in an hour or less you can have deliveries made to you. For most other sorts of deliveries, all you have to do is say that you are over 18. There is there's no further checks. It can be delivered to anybody in the household. Everybody seems to be struggling at the moment, that we've heard from, about statistics that are showing there is harm. I mean, clearly there must be, but when you make recommendations like this, when you want to change things, it helps if there is either anecdotally or statistically some agreement that this is actually causing harm. Because the counter argument is adults can choose how they should behave. I'm not sure I agree with that, but so I'm just wondering, in your own work and the support that you're providing to the people that come to you, have you had anyone say, this really got worse in COVID when I had a much easier access to it?
Yeah, actually, on the weekend I run an exercise group for people who identify as being in recovery from substance use, and we had a new member join us on Sunday, and I was walking alongside her, and we were sharing our stories around substance use, and she was a lady in her early 50s who said to me, I didn't start drinking until my late 40s when COVID hit, and that was due to the isolating nature that we found ourselves in. But then she had access 24/7 to alcohol. So that was an example there from just the weekend. And I've been involved in the drug and alcohol sector for over 10 years in different roles. But post-COVID, the presentations that we had was a significant, or what I witnessed was a significant rise of people in their mid-40s, mid-50s who were presenting, who you wouldn't see as traditional people accessing services. And that was a lot of coming out of COVID, and then that realisation that the substance use had gotten a hold and they needed to seek some support around that.
So do you...
Can I just respond to that in a couple of ways? So just in terms of both your questions, just the prior question around that delay in help seeking. We've done a lot of work in schools, and I think there is a clearer message among young people around alcohol, and we've seen that in reduction in alcohol drinking during adolescence. But the overwhelming evidence shows that young people still see this issue as highly stigmatised. So what that means is they're unlikely to put their hand up for help. So even though they recognise, so a number of studies we've done has shown that even though they recognise their peers might be drinking in ways that they're concerned about, they don't know how to have a conversation, they don't know how to reach out, and they don't know what to do. And certainly in the people we see in treatment, most of the people we see in treatment tell us that they've been drinking, like Ben's story, from a young age, but that nobody is actually in the community or in their friendship group to put their hands up to know how to help. And that's because I think we have a very confusing message around alcohol in the community. Obviously, the bulk of our alcohol messaging comes through the alcohol companies that obviously tell us that alcohol's the sort of drug for all occasions, and there's no harms. We don't have any community public messagings around alcohol. In my time here over the last 2 decades, I've never seen a government advertising campaign promoting the idea that this is an actual health issue and that treatment is available and this is how you access treatment. We see that very much in the gambling space. I think one of the things we can say that is positive around gambling at the moment is is that there is a very clear message around where to get help. There's no message about where to get help for alcohol and drug problems. And so people don't actually know. And there's a prevailing community myths that alcohol actually is around personal responsibility. It's about bad people making bad choices. It's not about the fact that the drug is harmful and that it can create health issues, that there are opportunities to get help. So we need to change that community perspective. Most people in the community don't believe that when you have problems with alcohol and drugs, that treatment works. So people don't put up their hand for help, and they only put their hands up for help when things have got so bad that there's no other choice. So that's why we see that astonishing 18-year figure, is because people need to know that help is available. They need to be confident that help is available, and families need to be supported to know what to do. Just on your second point, we run a national surveillance system for the Australian government through the Australian Institute of Health and Welfare, where we look at ambulance attendances across all jurisdictions for alcohol and drug, mental health, suicide presentations. What we saw during COVID is a huge increase in presentations for alcohol intoxications. What was interesting is that normally it's in lower socioeconomic groups that we see a higher rates of alcohol intoxication. But I think COVID was the great leveller, so that when people were at home, when we cut off people's social support networks, when we put people at home and don't have anywhere else to reach out, we saw a huge increase in alcohol presentations for people in higher socioeconomic groups. And certainly that's what we've seen in our treatment services as well. We're inundated at the moment, both I work privately and obviously through Turning Point, with referrals for people who are struggling with their alcohol since COVID. And that's largely driven by the fact that it was widely available and actually endorsed as the key coping strategy for COVID. That was something that was commonly talked about, that alcohol is a way everyone looked forward to knocking off from work at home and drinking, and the industry actually promoted alcohol parties.
Can I just ask, have you got data about that you could send to us?
Definitely, we can provide that data with you.
That'd be great. Yeah, thank you.
Okay. Sorry, I had another question. Yeah, okay, so, yeah, we might come back to it. Yeah,
All right.
sorry.
Monique, do you have a question?
Yeah, thank you. I'm really interested by the observation you made about the fact that we've never really, as a government, as a country, sorry, had a government that's called out the harmful effects of alcohol on the general population. In fact, we've had a long tradition in this country of governments which have raised money from alcohol excises and the like, and going back to the Rum Rebellion, we've had, government entrenchment with that industry, I guess. Are you able to give us any examples of countries, overseas countries, other spots where people have undertaken that sort of, national attempts to limit engagement with alcohol by people?
I probably need to take that question on notice, and I'm happy to provide that information around those particular campaigns. I think it's fair to say that it's interesting that the government has been very good at talking about the harmful effects of tobacco and promoting that, the harmful effects of gambling and promoting that, the harmful effects of drugs and promoting that. But yeah, there's radio silence on alcohol, and I think that speaks to the sort of the confusion within the community around what is alcohol. Is alcohol a legally sanctioned drug that is harmless? I think that's what most of the community generally believe. And so, yeah, I think there is opportunities in that space to sort of, as you would have heard with the last people presenting, there is obviously enormous evidence around the cost to the community around alcohol. And I think, we need a more coherent national strategy that speaks to that.
Thank you. Ben, thank you for your generosity speaking about your own experience. What would, if you went back to your 13-year-old self, what do you think would work in telling that 13-year-old self not to engage with alcohol to the extent that you subsequently did?
That's a good question. I think looking back at when I was a young fellow, I'm not a big fan of fear campaigns, and but like what Dan says, that there's nothing there about alcohol use and the impacts, and I do remember the campaigns that were there around drugs, and I was always extremely cautious and was no around drug use as a young fellow. that changed later. But yeah, so I think again potentially it comes back to more of that education piece around the impacts of alcohol use. Yeah, I think that's where I would go with it.
Can I also just say that at the moment we're working with New South Wales Health to look at the revising the national drugs school principles around drug education they haven't been revised since 2004, and some of the work we're doing in that space is speaking to schools around how they implement those principles. I think talking to schools across the country, I think one of the things that comes across is that schools aren't really aware of the principles or don't know how to apply them into practice. And I think this is a sort of a common issue in terms of we create these principles which are great evidence-based documents, but we don't invest in implementing them into the real world. And so many schools are left to sort of implement drug education sort of without much guidance or support. So I think there's huge opportunities in terms of, like we've done in other areas, and I think there's been a larger investment in mental health in terms of how we equip schools to embed alcohol and drug education within the school curriculum and to sort of reinforce opportunities around help seeking and support.
I guess, you know, I'm about your age, but I agreed that when we were younger, we used to, you know, drink a lot. We also used to baste ourselves in baby oil and burn ourselves to a crisp at the start of every summer. We've learnt not to do that. So I guess all these public health things could be taught together to some extent: drugs, alcohol, you know, other harmful industries and potential exposures that young people could have. But we don't really have a national curriculum for anything like that.
And I think the other thing just to say is around, like, just coming back to this issue of help seeking. We know that in terms of, if we look at things like depression and HIV, the thing that changed community attitudes around how the community sees those was campaigns that talked about the effectiveness of treatment. So we know if we actually tell the community that these are real conditions, that treatment is effective and available, that massively shifts community attitudes around how they perceive and understand the issue. So I do believe that we have national campaigns about promoting help seeking, promoting the fact this is a health issue, that in some way sends a message that you can get into problems with with alcohol, and that, you know, treatment is effective, and it encourages people to put up their hand for help.
Thank you. Thanks, Jeff.
Professor Lupman, I wanted to ask you, I wanted to look at the problem from a slightly different angle, if I may. What do we know about genetic predispositions to addiction? People who are likely to be addicted to alcohol or other drugs, likely to be addicted to video games or pornography. Is there something, is there research to indicate any of that? And can we identify people in the community who are more or less likely to be addicted to various substances?
Yeah, thanks for the question. I mean, I think we have very strong genetic evidence, mainly in the alcohol space, just because of the research that is done that shows that alcoholism is highly heritable. So if you've got a biological risk factor, so a family member with an alcohol problem, that you've almost one of the highest risk factors for developing a problem yourself. And obviously genetics alone, as we know for all sort of health conditions, isn't a predictor of what will actually happen, because there's huge interrelationship between genetics and in the environment. But certainly it's a major risk factor, and obviously that is something that, again, is part of how we're supporting the community and helping them understand sort of how to manage their mental health. That's information we should be sharing.
And is there any link between people who have a genetic predisposition to alcohol addiction and people who are addicted to other drugs? What do we know about people who are addicted to those other drugs as well?
You know, it's a great question. Unfortunately, there isn't as much literature in that space. Unfortunately, we don't know as much about that, but the evidence that is existing shows that there is an increased risk for development of sort of a broad range of substance use disorder. If you've got that genetic risk, I think it's around the availability of what drugs are available in the environment, and that increases the risk. And
is there a crossover between people who are addicted to alcohol, or I go back to video game addiction too, because I'm thinking about sort of younger people on a pathway, as it were, people who are addicted to those things that, you know, are also later addicted to harder drugs and so on. Is there a sliding scale? Is there a pathway? Do you see people who start out addicted to alcohol and they end up being addicted to heroin or ice or that? Not everyone is going to go down that pathway, but those people who are addicted to those most harmful drugs, have they started out? What do we know about the evidence that alcohol's been a gateway or otherwise for them?
Yeah, I mean, I think the evidence is, well, so a couple of things to say. First of all, I think we're here talking about vulnerability. So who's most vulnerable to develop problems? And obviously we know there's a range of factors that make people vulnerable. So that is genetics, that is the social environment in which they grow up, that is issues of underlying mental health, and that is issues of trauma or abuse. And we know that most people are using substances who get into problems with using substances because there's underlying issues that they're trying to address. I mean, with alcohol and drugs, we're talking about really powerful emotional analgesics, so emotional painkillers. Often people start using them in adolescence to deal with some underlying problem. And for most people, as we know, the majority of people who use don't develop problems. But for the people who do, it's often because it's a solution to another problem, and we're not dealing with the underlying problem. Just in terms of that transition to other drugs, I think what is the biggest predictor of what people use is the availability, what's available in the community. So the more available a drug is, the more likely that people will use that drug. And so that's what we see in different countries where alcohol is available and other drugs are more available. We see people making choices based on what's socially acceptable and what's available.
Given we know about the predispositions, as it were, from a range of different factors, to what extent does that actually inform any of the policies that we're making? Because it seems to me that we're kind of throwing darts at a board in relation to policy responses, other than, say, the law enforcement stuff, which is dealing with the problem that's there. And yet we've got this evidence and this information that there are groups of people who are more or less likely to be to have addiction issues. How do we marry those policy responses up?
I mean, I suppose I spoke in my opening comments around stigma. I think the reality is when we talk about this, we don't like talking about this issue, and that's true across a number of national strategies. So we know that if we're talking about a national suicide strategy, we're talking about domestic violence, if we're talking about road injury, we know that these issues interplay and have a major impact on the outcomes of all those national strategies. But often in those national strategies, we're silent on this issue because it's an uncomfortable area for us to talk about, and we haven't really developed a really clear national sort of conversation around what we should do in this.
So I take your point about stigma, and I take your point about the need for some national campaign that it's okay to get help about addiction. But I'm actually looking at, well, in terms of the identification of the group of people, what are we doing at, particular policy responses for that, because it's obviously a broad group of people, but it's certainly not everyone in society. And I think sometimes what we might be looking at is, just because of the nature of our roles as legislators, you kind of think, well, one size fits all, but actually I think we're looking at a more narrowly defined group. How do we better target that narrowly defined group for policy responses? there is really great evidence around primary and secondary prevention for alcohol and drug harm. We know that there's a whole range of programs that can identify at-risk populations, and that's at risk for alcohol and drugs or at risk for mental health. And there's really great evidence-based programs about what can be implemented both in schools and in early adulthood. We don't invest in those strategies at the moment. In terms of drugs that are costing the system the most, obviously leaving alcohol aside for a minute, of the non-alcohol related addictive drugs, what are you seeing as the next biggest costs to the system?
So we were talking about illicit drugs, so obviously alcohol and tobacco are the biggest costs. I mean, one of the biggest issues, obviously, in terms of the amount of harm it causes is methamphetamine.
Yep.
So methamphetamine, again, is a drug, obviously, that's, in terms of stimulant, the purity of stimulants has changed enormously over the past few decades. And certainly that's what we see if we're talking in our clinical experience around what we see in clinical services. There's the huge impact of methamphetamine on presentations to hospitals, particularly in terms of mental health settings.
And in terms of the treatment to get people off the drugs to which they're addicted, does that change depending on the sort of drug that you're on in terms of best practice? So is the basic pathway for alcohol different to the pathway for methamphetamine?
No, I mean, I think across all addictive disorders, there's essentially a very similar approach in terms of the strategies that we know that work. I think one of the challenges, though, we have in this country is we have a very flat structure in terms of our responses. So we don't have. So the analogy I would give is that if we were treating cancer, for example, we just have a very blunt instrument, a very basic chemotherapy in terms of how we respond. We aren't able to, when people fail to respond to that treatment, we don't have investment in, I suppose, greater tertiary responses to that issue. So in cancer, if you don't respond, you can be stepped up to the next level of intervention. You can see more specialised personnel to help you with that. In the addiction space, we have a very flat structure where we only have, we have some really effective strategies, but if you are, because of this delay in help seeking, often people present with a whole range of complexity, and we don't really have the capacity to step up in terms of the amount of treatment offerings that are available.
What does the evidence indicate are the most effective strategies to get somebody off the thing that they're addicted to and keep them, as it were, off that particular substance?
There's a whole range of really effective strategies. So there's a whole range of medication options that are available across different drugs that we have shown to be effective. There's a whole range of psychological approaches and social approaches, but it's really that biopsychosocial approach that's tailored to the individual. So like in mental health, essentially there's a whole range of evidence-based strategies that we can put in place. The challenge, I think, in this country is that access and availability of those evidence-based practices are quite limited due to resourcing issues because the system is quite fragmented. I think it's fair to say if you had cancer anywhere in this country and you went to see your GP, you could be guaranteed virtually the same sort of clinical care pathway for that condition. I think, though, what we hear, and Ben can talk about this, is in terms of when people come to us looking for treatment, it's an absolute lottery for families what people get and what advice they're going to be given, and if they're going to be given the appropriate evidence-based treatment. So that is a huge issue for us as a community.
And is that because of the lack of availability of mental health professionals and psychosocial support, or is it because of the lack of access to the drugs that you mentioned earlier, to the medicines that you mentioned earlier?
I think it's fair to say that alcohol and drug treatment is not really seen as a health issue in the way that it's commissioned both at the federal and state level. It's sort of seen as something that sits alongside health. If you go to any hospital, for example, or any primary care for any other health condition, I think you can be guaranteed what we know is best practice. Alcohol and drugs, unfortunately, is often seen as sort of something that's separate and something that many health professionals don't feel competent in because there isn't a training pathway. It's rarely taught at undergraduate and postgraduate level, so people don't have the skills and knowledge to know the best way to respond. And that's a huge challenge. I know 20 years ago under the Howard government, there was an investment in ensuring that alcohol and drug education was embedded in university education. That funding obviously has ceased a long time ago. So it just means that because addiction is largely not seen as an area of high need, we have very few addiction clinical academics, which means that we don't get into the university courses to actually teach into those curriculums. So the doctors of tomorrow, nurses, allied health professionals really aren't skilled and don't have the requisite knowledge to know how best to respond. And that's why we have a very fragmented system that is not integrated with our current health system.
I was interested in your submission about the way in which you gather data about emerging illicit drug use through liaison with emergency departments and some of the blood testing and so on that they do there. What are you seeing as concerning emerging both legal and both prescription and illicit drugs that you're seeing people addicted to?
I mean, I think the trend that we're seeing across the world is the emergence of more potent compounds. So obviously, in an illicit drug trade, to be more profitable, you want drugs that are easy to essentially move about and easy to sell, and that means lower volumes of higher purity drugs. And what we're seeing is a new generation of synthetic compounds that are sort of growing over time. Certainly overseas, you know, one of the biggest things we're seeing is synthetic opioids, and obviously you'd all be aware of the challenging situation in the US around synthetic opioids and how that's sort of infiltrating other types of drugs.
Are we in danger of that occurring here too?
I mean, I suppose the big question is not if, it's when. I mean, I think we know now that we're talking about global drug markets, and we know from drug seizures that it is relatively easy to get drugs into this country. So the question is when these drugs will arrive and how prepared we are to deal with it. And I think it's fair to say in that opioid space, synthetic opioids, and looking at what's happening across the pond, that you know, at the moment we're ill-equipped to really deal with an issue of that magnitude.
What do we need to do to put ourselves in a position to best equip ourselves to prevent the harm that's causing in the United States? I thought a lot of that started out as being prescription medications that people became addicted to. Am I wrong in saying that?
Yeah, there's been essentially 4 waves of the opioid crisis in North America. So the first wave was overprescribing of prescribed opioids, which led to an increased number of deaths from prescribed opioids. There was then a clampdown on prescribed opioids and a surge in terms of availability of heroin, which led to the next wave. And then it was the introduction of the synthetics.
Different waves. Is the overprescription of opioids an issue here in this country at the moment?
I think one of the great things that has happened in this country is that the government has recognised what was happening overseas, and they've put a number of regulatory processes in place. So now we have real-time prescription monitoring systems in most states to support prescribers and dispensers in terms of how they're looking at that. So that's really important. And the federal government's put a number of measures around restricting access to particular opioids to move them back to being from over-the-counter to prescription only. So we have seen a reduction in terms of the risk associated with that, but certainly
limited quantities as well.
Yes.
You've got to say the PBS and TGA have been very good in this space.
They have.
Sorry, you were talking about the different waves, and you were up to the sort of heroin wave.
Yeah, so the second wave was the heroin wave, and then the third wave was the introduction of the synthetics, particularly fentanyl, and that saw a massive increase because it's sort of 50 times more potent than heroin. And then more recently, there's been a new wave with the more highly synthetic opioids, which are now being mixed with drugs like cocaine and cannabis and other drugs. So people are essentially, when they're buying drugs, unfortunately, those are often containing synthetic opioids, which creates, really dreadful outcomes.
And again, was the fentanyl a prescription medication, or it was all black market?
Yeah, it was all manufactured synthetic. It wasn't prescription fentanyl; it was manufactured synthetic fentanyl. So these are, drugs that are manufactured to have the highest impact and effect.
And again, what is Australia's response at the moment? I mean, you talked about the sort of the good regulatory measures we have in relation to prescriptions, but what about how well or otherwise are we prepared for those subsequent waves here at the moment, and what do we need to put in place to stop that happening?
Yeah, so I think there's been a few really positives. So I think the government has really supported the wide availability of naloxone, take-home naloxone. I think there's still some challenges in terms of how that's actually implemented in the real world and how people feel able to access that medication, but that's a real positive. But I think, we really need...
You should explain what that does.
I'm the non-doctor on the committee.
So naloxone is basically the antidote to opioids. So when people overdose, if you give them naloxone, and now we can do naloxone through a nasal route. So if we intervene early and spray naloxone up somebody's nose, that reverses that opioid overdose. So that's really important in reducing deaths as associated to opioids. So that's a really great positive step. But I think overall, I suppose what we need to do is look at the system level. So we need good intelligence to know what's happening. We need to be able to share that intelligence rapidly with health and all branches of health to sort of understand how to respond. So we need to let the community know what is actually happening. And so, again, I think we're seeing obviously some introduction of pill testing in a number of jurisdictions now. So that lets the community know. And certainly if you go to Europe has a very sophisticated mechanism of pill testing, so that as soon as a drug gets detected as being potentially harmful, there's wide community alerts to sort of inform the community about that, and we see a reduction in the likelihood that that drug is going to be used by the community. So I think it's about system intelligence, about community awareness, and I think it's about making sure that evidence-based programs, so for example, opiate agonist treatment, which is a treatment to substitute opioids onto more long-acting opioids, that's incredibly effective. But there's a real challenge in this country around encouraging prescribers across the state to use it.
Programs. Yeah.
Yeah.
Good. I might have to interrupt.
No worries.
There, just give Michelle some time. Sorry.
We have, as you said, fragmentation of services. We have fragmentation of policy. It's piecemeal. It's a hodgepodge all around this country. There was, to my understanding, a ministerial body that was disbanded in 2020. It had representation of health as well as justice on it. Do you think that we need to reinstate that or something similar to that, and who should be on that body?
Yeah, absolutely. I think what we had previously was a mechanism where Commonwealth and jurisdictional representative came together. It was both health and law enforcement. And it was a huge opportunity not only to coordinate efforts, but also to learn from each other around what's working, what's most effective, and to think about what could be implemented in different jurisdictions. So it's a great mechanism for learning and sharing and actually having sort of a coordinated approach. That's been missing.
Sure. And are you supportive of the same people being on that, the same representatives from health as well as police, law enforcement, or would you add any more?
Yeah, I think it's about also having representation from experts, clinical experts and lived experience. I think that's a really important mechanism to think about how they feed into that process. Because I think in other areas of health, Australia are world leaders in looking at what the health needs are, what the evidence shows, and how we implement that and roll that out across the country. It's a very fragmented piecemeal approach when we're talking about this issue, and I think we need to get serious on how we deliver more effective approaches in a way that's nationally coordinated.
Second question really drills into treatments. The treatments we have, they haven't really changed a lot in many years, and they take a long time, which is part of the, and also this is labour-intensive work. This biopsychosocial model is labour-intensive work. We have an emerging body of data, preclinical data supporting the use of GLP-1s, and it's an exciting area. This has been described as the Swiss Army knife of drugs, but they absolutely do seem to have some efficacy with respect to addiction. Where are we at with phase 2 and possibly phase 3 trials with these drugs?
Yeah, I think that's a great point. I think just in terms of those drugs, that there are a number of clinical trials that are happening internationally at the moment with those drugs that really show promising findings. I think there's a lot more, there's a lot more candidate pharmacological agents that are currently available that makes it an exciting time. But I think because of stigma, this is an area that pharmaceutical companies don't really want to invest in. Again, they don't want to be associated with a product that's seen to be working for a community that they're seen as
they
sort
don't
of
have
not
to invest.
fitting.
Government can invest.
Exactly.
There's government funding available.
That I was following on to that. So because we don't get pharmaceutical company investment like we do in other areas of health, I think it's important that the government does invest in that, particularly because you would have heard, the impact on burden of disease, the impact of cost to the Australian community. There used to be, I think a decade or more now, funding for working research grants in the alcohol and drug space. There used to be, I suppose, specified funding for that. I think because of the level of community harm, we need to think about different government mechanisms for funding research in this area, because it's a higher priority area that isn't invested in by other funding bodies. But because of the lack, essentially, the limited and smaller academic workforce in this space, often we're competing with very well drilled and funded other areas of health.
So you're saying a targeted funding call for this?
I think targeted funding call. I think for us to make major advances in this space, we need to have really targeted funding to look at some of these promising mechanisms and look at what we can do to improve.
With the clinical trials that are running overseas, can you tell us a little bit about them, particularly the bigger ones? Are there any phase 3 trials using GLP-1s?
My understanding, yes, there's a number now running, particularly in the US, and I think there's one that's just finished in Europe. I can certainly provide that information.
That would be great. And the question around stigma is interesting. Stigma, of course, I understand that. Are there any cultural differences?
In terms of stigma? I might throw that to Ben, just in terms of your experience of seeing different people present.
Yeah, I think absolutely there's... with my work experience in this space, a very low representation of people from different cultural backgrounds, with the stigma associated, especially with substance use. I've worked with a variety of people across different cultures. Asian cultures, there's a big a lot of shame put on the individual who uses it within the family unit. So there's a real reluctance to engage in treatment services. So I've seen it on that side of things as well. Yeah, I don't know if you want to.
Yeah, I would say two things. I would say, certain communities, particular communities, obviously have additional stigma and discrimination for LGBTIQ and Aboriginal Torres Strait Islander peoples. We know that alcohol and drug issues and that issue compound that shame. But we know that certain cultural groups, it's seen as something that is not discussed and brings shame on the family, and we see that play down into less attendance and less presentations to services. The other point I want to make is about women as well. So we also know that women also have compounded stigma around when we talk about addiction. Women are seen as sort of lesser compared to men, and that's seen in
Not in this committee.
not in this committee, but certainly in the community. And certainly when we look at services and who presents the services, men are much more likely to present to services. We also run telephone and online services. Women are much more likely to call those services than men. So
Just on that point, should we have, for example, detox centres that are gendered, that have separate, units for men and women? Or are they currently mixed, or is it variable right around the country?
So at the moment, I would argue that the treatment facilities that we have are poorly resourced. So in some ways, we're lucky when we have units that actually provide treatment to anyone. Ideally, in other parts of health, we've seen that split into gender-specific units. I think that we also know that many of the women that present to us often are victims of violence and trauma, and putting them in situations that they may feel at risk obviously might in some ways delay the decision to seek treatment. So I think those sort of initiatives would be really welcome. I don't know, Ben, if you want to add to that, or...
I wanted to go back to Michelle, where she's talking about pharmacy, and I'm all for pharmacological approaches to supporting people accessing treatment. But I think alongside that, we need to be having lived experience workforce that's well developed and supported to help people stay connected to service and to provide people with hope and optimism that there is a future for change. And when you can see that with somebody who's there with you along that journey, that's really beneficial for that long-term recovery rather than that sort of short-term crisis management. So I just wanted to make that point as well.
Point taken. Do you think that we need to have a broader repertoire of inpatient residential type services? So, for example, I understand yesterday, based on a visit we made to Windana, that there are about maybe 8 or 9 of these residential centres around Victoria. However, there's a cohort of patients who are clearly going to be very high needs, and they would probably be better managed in a hospital, which has all the resourcing, including 24-hour security, nursing, diagnostics, you name it, at its disposal. And I do wonder whether we should be looking at designated inpatient beds, funding them for hospitals, so that that really, really challenging group of patient can be managed there rather than falling through the cracks and not being appropriate even for residential community care. What are your thoughts on that?
So I would say to you that the number one mental health condition treated in hospital beds is alcohol and drug problems.
I know, I treated them, so thank you.
It's not to say that they're coming there to actually for specialist treatment, they're just people who end up getting admitted to our general ward. So we're already seeing them in hospitals, but we actually don't designate or actually provide any funding to actually provide that level of treatment. I think in our submission what we talk about is thinking about a national strategy, to think about demand modelling, to think about creating a system that is fit for purpose. So it's thinking about what the needs are of different levels of severity of harm and what the relevant support needs to be in terms of that sort of incremental support across the community. So, yeah, I think many of the services you would have seen are not set up to manage people with really severe, complex mental health and physical health issues, and we need to have other solutions. But that speaks to national planning and a really good coherent strategy around what's in place. We see that for other health conditions. We just need that in this space.
I might just interrupt there.
Thank
just I have a couple of questions. And Ben, if I can focus on you for a minute, and thank you very much for sharing your personal information, and I don't want to be too intrusive, but thinking about how we manage alcohol addiction, what would have helped you? Would it have been less supply? Would it have been cost of alcohol? Would it have been early access to psychological support? And if I can just preface it, we've heard a lot about a two-diagnosis model of addiction, the addiction and the mental health problems that contribute. How do you think we should be formulating policy around that area?
Initially around what would have helped early days. So I suppose by the time I was 23, the consequences of my drinking were starting to become visible. Lost my licence at 23.
Because of an accident?
Drink driving with a booze bus. So while from the outside looking in, you could go, you're making some bad decisions around your substance use. I wasn't there yet. It was more, how do I need to get smarter about my drinking? But I knew internally that, while these things were happening, I knew internally that my drinking was not normal compared to other people that I was, like my siblings. I'd look at them and go, they can stop, but I can't. But there was this, I can't speak to that because of the shame I was feeling around that as well. And that's that internalised sort of stigma that I had, that I'm a useless person because I can't stop. But I didn't know of anybody who had those sort of problems. Like, I didn't know who to confide in about that. My parents here and there would say, look, you're drinking, we're concerned about your drinking, and I would minimise, that's fine, I'm okay, I'll reduce here and there. Like, it's really concerning, like access at that time, that there was no online deliveries then. I'm talking sort of 15 years ago with my drinking. So for me, like, being forced to go to a bottle shop to buy alcohol every day, that built the shame, and that was a compounding factor which I think contributed to me putting my hand up for help. So I think access these days is a big issue that we could look at. How do we, because I think now with online deliveries it's so easy, I don't get to experience that that guilt and shame and remorse around how I go about getting my drugs or getting alcohol. So I think our policy around our access, it could be a starting point for sure.
What about cost?
Cost, absolutely. There were numerous times where, like, I would go paycheck to paycheck, and I would have maybe $20 left in my wallet, and I would choose buying alcohol over food. But it would be the case of, I know I can buy a cask of wine for $4, and that's going to serve. And that's, those last few years of drinking was just cask wine, because it was cheap and available and easy to get. So certainly, pricing will certainly have an impact for sure.
And have you been left with any physical effects of your drinking?
It's been 12 years since I've had a drink. It's the, as I touched on before, it's the cognitive side that I know has been impacted by my substance use, which impacts my mental health quite significantly. It impacts the way I interact in the community. It definitely impacts the way that I present at work. And with my substance use, there's a lot of guilt and shame around some of those behaviours that I engage with. There's, like, when I'm heavily substance affected, I engage in behaviours that I normally wouldn't do, and I cross my values, and every time I'm crossing my values, I'm impacting my self-esteem and self-worth. And while I've moved from that point to here, there's still guilt and remorse around missed opportunities, and and some of the things and behaviours I engage with. So that stuff still lingers. But I'm at a space now where I can utilise that experience to support people and use that as a positive to help people navigate their way through and into recovery, which then feeds the self-esteem and self-worth and go, well, all that pain and anguish is now a tool to help somebody sort of provide them with a bit of hope and optimism for the future. So, yeah.
Good. Well, thank you very much for sharing your experience. I just have one last question to you, Dan. You've talked a lot about being overwhelmed at the moment. How long are your waiting lists, and are people missing out on treatment because we don't have enough resources?
Absolutely. I think every day I get a email or a call from a family member or an individual asking for help. We run a number of helplines across the country, so in here, and also a national online counsellor service, counselling online. 40% of people who call that helpline are new to treatment. And certainly when we look at wait lists, speaking here in Victoria, we know that often it's at least 3 months before people can get help. I think when people put their hands up for help, you know, as Ben has really articulated, there's a lot of shame and guilt, and I think we need to seize that opportunity to sort of give people access to treatment as soon as we can. So it is a huge missed opportunity at the moment, and I think, we need to make it easier for people to get treatment. We need to make sure that when people put their hands up for help, they can access. And I think there's a lot of opportunities that we've seen. If we just look at the mental health space, we can see how much investment there've been in making it easier for people to access. And I think, unfortunately, in terms of telephone, digital health solutions, we know lots of people, because of shame and stigma, are often reluctant to come to face-to-face services because they're often reluctant to be identified. They're worried about confidentiality and privacy because of the stigma associated. So we know that, you know, if we're offering telephone and online support, we've done a number of trials that I can share with you that have shown that it's really effective in reducing people's alcohol and drug use. They're really accessible, they're really timely. We see more women put their hands up for help. I think we just need to replicate what we see in mental health and have a greater investment in that space, because we need to make it easy for themselves and families to get the help they need as soon as possible.
Great.
Can I just ask one question about the helpline? There is a physical impact to addiction. If you're talking to people, how do you deal with that physical impact? Because can you link them back to their GP, or because, you know, if you're doing a lot of alcohol, actually withdrawing can be painful and detrimental in the short term to your health at that time.
I'll just make 2 points on that. So absolutely that we need to address physical health issues as well. You know, we support, we run a support service here for health practitioners, so we have a lot of GPs calling us for support. GPs feel overwhelmed in this space. Yeah. They feel underskilled and don't know what to do. If we look at other, for example, if we're thinking about dealing with tobacco, we have a really successful model in this country of quit lines. So quit lines provide a comprehensive package of support. They support GPs to provide good clinical practice around dealing with physical health issues, looking at pharmacological solutions. I believe that if we did a similar model of that reactive helpline where we help people, we provide a whole range of support, that will give confidence to GPs to work more in this area. If they know they could be supported by somebody at the other end providing that other type of treatment, we could support GPs to provide withdrawal management. We could help them navigate the system. I think we could really escalate the response in this country to provide a much more comprehensive and supportive treatment offering.
But what do you do now? If I rang you today and I want to stop drinking, how do you determine, do I need extra physical help on top of that?
So one of the challenges we have in our helpline services is that I think our helpline services were designed for the 1980s. So we provide a reactive call. So we wait for people to have the courage to put their hands up for help. and when they ring, we're only funded to provide a one-off call. So basically, we're offering either managing people who are in crisis and doing some crisis management, or we're suggesting and giving them the numbers of where the local services are. What we would like to do, like Quitlines do, is have that proactive approach where we're able to hold people's hand, support people on that journey, connect them to services, and make sure that they get early effective treatment.
Okay, thank you.
Good. Well, look, we have gone over time, and your evidence was extremely valuable, so we thank both of you very, very much for giving us your time today. If you've been asked to provide any additional information, could you please forward it to the Secretariat by no later than Tuesday the 12th of November 2024. You'll be sent a transcript of your evidence and will have an opportunity to request corrections to any transcription errors. And once again, thanks very much, and particularly to you, Ben, for giving us your personal details. So I know that's been very important to us, and we're grateful. So thank you.
Thank you.
Thanks, Dan. And I'll now suspend for a short break, and we will return at 10:42. public hearing being held on Mantra and Russell of the House Standing Committee on Health, Aged Care and Sport for the inquiry into the health impacts of alcohol and other drugs in Australia. In accordance with the committee's resolution, the 4th of August 2022, this hearing will be broadcast on the Parliament's website, and the proof and official transcripts of the proceedings will be published also on the Parliament's website. I now welcome Dr. Paul Grinzi from the Royal Australian College of General Practitioners to give evidence today. I welcome you. For the Hansard record, before giving evidence, would you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a short opening statement before we proceed to discussion.
My name is Dr. Paul Grinzi, and I'm here on behalf of the Australian College of General Practitioners. And I'd like to thank the committee for the opportunity to bear witness to this inquiry. The RACGP, if I can use that term, is the largest professional general practice organisation in Australia, and we've got over 50,000 members. I just want to, in my opening statement, just outline a few things from our submission. So we focused on the equity of service delivery, the effectiveness of current programs, and the roles of various sectors in prevention and recovery. We wanted to highlight the need to properly address substance use. A collaborative approach is crucial and should involve all those involved, including health professionals, social services, together with community engagement. As GPs, we play a key role in the front line with patients and their families, addressing chronic disease management and preventative care involving the harms associated with substance use, which can be a variety of health problems, dependence and social issues such as violence and homelessness. So we cover a broad spectrum of the effects. To improve access and effectiveness of AOD services for all Australians, the RACGP recommends a few things. To help further support the ability of GPs to address chronic disease, we are recommending an increase in Medicare rebates for longer consultations, namely the level C, which are over 20 minutes, and level D, over 40-minute consultations. In addition to an increased Medicare rebate for those patients that are living in MM3 to 7 areas, so the rural and remote areas of Australia. And this is to facilitate longer consultations focused on chronic disease prevention, which includes but is not limited to substance use presentations. Longer consultations are a great opportunity to address major risk factors, including drug and alcohol use, and they allow more time for the broader whole-of-person preventative care and early intervention chronic conditions. Secondly, we'd like the inquiry to consider further mental health support through Medicare rebates. We're recommending a 20% increase in the GP mental health MBS item numbers to better equip GPs to be able to spend the time and prioritise mental health, which is commonly intertwines mental health conditions and AOD presentations, including engaging a broader sector approach around education, particularly looking at education for general practitioners around the overlap between education, employment, justice areas that overlap with health, to create a supportive environment of people experiencing AOD harms and reduce AOD-related health. Our third main recommendation here was basically to learn from domestic and international best practices that emphasise inclusive care, particularly for vulnerable populations which we're serving, and optimise cultural competence to improve the service delivery of GPs. Critical components of this again include education and skills development, with ongoing support for primary care clinicians to improve their understanding and confidence in comprehensively managing AOD issues in people they see, including particularly vulnerable populations. Specific funding support opioid dependence treatment in the primary care setting is important, and we also recommend an item number consideration for long-acting injectable treatment. The initiatives around that to help support greater integration with general practice and other specialist services in non-government organisations and state-funded services as well. In conclusion, I want to reiterate a collaborative and multifaceted approach. This is the best way to address the health impacts of alcohol and other drugs in Australia, particularly for priority communities. If we implement inclusive policies, supporting appropriate training and drawing from best practices, we can enhance AOD services for the community and contribute to more equitable healthcare systems and happier and healthier Australia. GPs see the majority of Australians every year. We're cost-effective and an accessible service and play an important role in the prevention and early intervention in collaboration with specialist AOD services and ongoing care. We see all individuals and their families as an important part of the community, and there is no substitute for the quality care a GP can provide and the practice team. We know the patient, their family, the history and the community.
Good, thank you. We might start with Michelle. Do you have to?
Thank you, Dr. Grinzi. I just want to talk to you a little bit about prescribers, specifically GPs who have competency in opioid prescribing. I understand that we're seeing a departure of GPs from this sector as they retire or they give up. I'm quite alarmed by this because obviously these GPs can have hundreds, sometimes even thousands of patients on their books, and when they leave the sector, it's a huge loss. Can you just maybe tease this out for us and talk to us a little bit about what you think could help arrest this decline?
Yeah, it's a shared concern. And as you may be aware, different states have different systems and different structure. I've been working here in Victoria, so I'm very familiar with the Victorian system as well as somewhat familiar with other systems, so I can't speak nationally with great expertise across the board. But there has been historically, I suppose, a burden of treatment placed on a generation of GPs who are now peri-retirement. And at that age, we also become unwell ourselves, so some of those are retiring prematurely compared to what they had planned potentially. And over the years, they've generated often a lot of them have generated a large patient base, and so once they come out of that workforce, that patient base is needing to find other prescribers. I've been involved with the Victorian Department's education program for GPs and other prescribers for a number of years. And we've had continuing increased uptake of education. So the amount of doctors wishing and engaging in the training program certainly hasn't dropped off. But the amount of translation from having been trained to actually prescribing in reasonable numbers, there's a big gap there. You may be aware that a few years ago...
They've had the education training, but they're still not making that leap to prescribing. Is that what you're saying?
Yes, yeah.
So,
a lot do,
yeah.
But there's still there's a gap. It's certainly not a one-to-one translation by any means. So does that suggest that they're coming out of education without the confidence to actually make that step into prescribing? That's what I thought. And I was involved with, you may be aware, the department funded the college to run an AOD education program nationally, which I was involved with a few years ago. And so I thought initially was basically stigma by GPs of this sector, lack of confidence were key drivers. And in being part of that education program, I got to speak to the GPs nationally, and particularly the ones that were, in this case, that interested but not doing anything, what was going on. And my experience from having those discussions was more about system barriers, actually. For example, one GP said, I'd love to be doing it, but particularly after lockdown and COVID and all the extra mental health that's been sort of flushed into the system from that, I can't deal with more complexity without more support. And the support they're describing, and I certainly reflect that on my point of view, is both support from others. GPs often have felt like they're held in the can. Patients aren't sick enough to get to the AOD services, which are limited in access, but a bit too sick in this case, if I can use that term, for them GPs to feel comfortable around that. So the lack of easy, accessible referral pathways for that middle ground is challenging, and also a lack of support from a system point of view. So coming back to the submission here, as you may be aware, the MBS is very skewed towards shorter consultations in terms of the remuneration for patients with their rebates. And so it's for GPs looking to do more longer consultations, which this area does require. It is complex. It does affect lots of parts of life. There is a disincentive to actually do that. So other areas look at that.
But you see, the problem I have with just calls for increasing rebate, is that there's no guarantee that out-of-pocket expenses won't increase. There's no guarantee from any GPs anywhere in the country that even if we tomorrow raise a rebate by 20%, that they will either hold out-of-pocket expenses or eliminate them. What I've observed with Medicare, and I think this is a design flaw across the whole system, is that rebates are not the answer. Rebates and out-of-pocket expenses seem to rise in parallel over time, and then the next year we have GPs coming saying we need more money because of X, Y, and Z. So I just want to sort of challenge you, tease this out. I don't necessarily. I think increasing the rebate could happen, but it's a short-term fix. It's not a long-term fix. What is the long-term fix? Is it nationalising a series of clinics or services where prescribers are paid a salary, for example, by the Commonwealth, as, for example, medical specialists are done in hospitals?
There's other models. I have, and you've got fair criticism of the Medicare rebate. I think historically it's fallen so far behind real costs that increases would need to be significant to add up to that. I think, hypothetically, if we got to that point, the out-of-pocket costs would stabilise, but there's a fair.
I don't know that it would. I'm not convinced that it would.
Okay, well, we don't know, but we're unlikely to get there in the current fiscal arrangements of the country as well. So maybe that's an area we have to move away from. Other models, I think, from a GP point of view, the strengths we've got is firstly access to the majority of Australians see a GP within the previous 12 months. So they're seeing us regularly. We are experts in the generalism of a whole person. So not just the physical health areas, but also the interrelation of the community we're working in, the family dynamics, as well as the various health things. So AOD, particularly alcohol is a good example, affects almost every system of the body and affects social and psychological aspects. So it's really complex. And this is the area that we're specialists in. We sort of, I won't say thrive, but we're experts in juggling various aspects around that. So not just a single organ issue. We're not just looking at AOD, but looking at AOD in the whole of person. So there's a real opportunity for general practice to optimise its engagement. And again, coming back to some GPs that I've spoken to about what their barriers are, it's often that if I look at that, they reflect on the mental health changes of the 90s, where mental health was a stigmatised topic. I can't say that's 100% improved, but it certainly is improved, and very inaccessible in terms of services. The MBS was completely overhauled, mental health item numbers were put in place, and the psychology sector flourished as part of that system. We don't have the same flourishing within the AOD sector to support general practice. So I see general practice as really a core part for that patient to be touching, touch points throughout the year potentially, and then we help coordinate that care. So we can hold on to most of that care, but when it gets a bit complicated, if we have pathways we can access more readily. Now, whether that's another clinic or whether it's a secondary consultation service, those sort of things need to be considered. One of the issues with another clinic taking over or initiating care, and we've seen this with a number of attempts in Victoria, is that a specialist service may start a patient, for example, on Suboxone treatment for, let's just say, oxycodone dependence. And the idea was to stabilise them and hand them back to their GP. And often there's a patient barrier there of I've got a trusted relationship with my new prescriber, my new system, and then why are you dumping me onto my GP, which is not what the intent was, but how it's perceived. So in starting treatment for a very stigmatised and embarrassing topic for a lot of people, they have to develop a bit of trust and rapport with the service provider. And if it's a primary service provider who's not designed to continue that care longer term, then there's a mismatch, because now we're getting people who don't need that specialist care sort of stuck emotionally to that care, and those that can provide that longer term continuity and the broader healthcare are sort of missing out. So I caution around just having more clinics to start things. That would, again, be quite short term and would work. We'd get, take patient numbers there. But overall...
But then what's wrong with that? I mean, why couldn't a patient just stay with those they've formed a therapeutic alliance with an alternative provider. It's going to be long term. It's a stable relationship. It's going to be funded by the Commonwealth, for example. Why couldn't they just stay there and have their care of that specific condition managed with that provider?
Yeah, it certainly could.
I mean, that's what happens in specialist medicine, right? Your cardiologist looks after you for years and years for your cardiac problems, endocrinologist similarly. What's the difference?
I would beg to differ from your opinion about specialist services. As I see them, they provide... There's some specialties that are very much outside of what general practice would be comfortable with, and certainly would take over a lot of that management. Most of the specialists that I work with sort of provide touch points of review and a consultation back to me of how I can manage my patient with, in collaboration with their advice. So it's that consultation rather than you've got a heart problem, I'll see your heart specialist and never see me again. It's really, I'm still very much coordinating and helping support that patient, particularly when a patient comes to see someone and come back to me saying, I'm not sure what's going on, help with that understanding of their health and what the new change.
But if we take a patient-centred approach here, or a person-centred approach, if the patient is happy to maintain a therapeutic alliance with that provider, what's wrong with that?
Nothing from the patient point of view. They'd be happy for that. I think the system would be overwhelmed, or that sector, unless you're throwing up 1,000 clinics. Eventually, that's going to reach saturation, and we're not. I think we would lose the value of that sector being specialised, and we also lose the value of, because it's specialised, it's now becoming what I call a single organ issue, even though AOD is not an organ, and we're missing that whole of person approach. And one of the challenges around the AOD treatment is outside of general practice, it's often seen as the only treatment. Someone who is stabilised on methadone, for example, or he's treated for an alcohol withdrawal and goes through rehab, that's seen as treatment by itself. And as a GP, you see, okay, you've treated that part and it's sort of stabilised, but you're missing the diabetes screening, you're missing the mental health, domestic violence. That's also part, 101 of other examples of other bits that are sort of related but not directly related. So my concern with a clinic, and that may will be part of the puzzle here, of putting some clinics out there to help decrease the burden on general practice, which is invariably engaged. But we also need to have a system involved so that the general practice doesn't move away, it doesn't fragment the care, that long-term care, and that broader care. Because really, our health is not just the drug use, it's the impacts on it and the other areas of our health as well that also lead to drug use often.
Yeah, okay. I think we have structural problems with the current GP funding model around complex care.
Absolutely. Yeah.
It's just not incentivised to provide care for complexity.
Yeah. At the moment, complexity is the current system is longer consultations and chronic disease management plans, and just what we normally do day to day, and it's disincentivised in terms of being able to do that. So if we're not looking at MBS rebate changes, then there needs to be some other support, because this is, regardless of whether it's AOD or not, this is an important thing for all of us. And so some long-term chronic disease, our age, population is getting ager, more and more chronic disease, and even for the same age groups in generations, our health complexity is increasing. So longer consultations are important. The short consultations you just can't cover, even if you're trying to drip feed it over time. You need time to actually sort through it and assess it properly and engage that patient so that they're involved in their healthcare. It's not just a paternalistic, here's what you have to do, which is what we want to move away from.
Right. Julian. Dr. Quincy, I thought I'd pick up Dr. Anandaraja's point that you finished off with there. Have you costed the changes that you're proposing here to the MBS schedules as to what they'd cost? And have you thought about the unintended consequences of longer consultations? I agree with Dr. Anandaraja that there's a fundamental problem. I think we all agree with that.
Yes.
What's the cost of doing what you've suggested?
I'd have to take that one on notice. I don't have the details of whether the college has costed the recommendations around MBS changes.
And what about this? I mean, if you have more people spending more time with their GP, you might get better health outcomes, but the waiting list should blow out to see your GP. I mean, I know in my own in the GP practice that I visit, it can be months and months to get an ordinary appointment. If you rock up to the sort of general surgery open thing because you've got something that needs to be seen that morning, you can get in. But if you're going to see something that's sort of, you want a bit more time, it's months and months. This is suburban Sydney, and I'm sure that's replicated right across the country too. I wanted to take you to the part of your submission on page 3 that deals with emerging issues in illicit drug use. I also wanted to talk to you about legal drug use and other substance abuses. Are you seeing much of an abuse of those gas canisters that go in whipped cream bottles, sometimes called nags, and people have been talking to me about that in the electorate? What can you tell me about what you're seeing in relation to the presentations of that?
Nags is one example. There's a few other substances that don't often present primarily to us. So the index person, the person who's using that, unless there's some sort of crisis that they're sort of forced to, often aren't presenting to GP practice. What we're seeing more often is that the families or friends related to that person expressing concern or asking for advice about resources of how to manage their son, daughter, husband, wife, whoever it may be, who's using the substances around that. So
What are the other sorts of things that you're seeing that are like nags that are?
I think amphetamines would be, methamphetamines or other amphetamines would be a similar one where unless there's a crisis, if I flip the question around and what we actually people present more readily for, it's certainly going to be smoking, alcohol, cannabis, the big three, and then opioids and benzos, probably because there's some pharmacology behind it of the treatment, so they can see that maybe patients perceive their role, and where there isn't medications available as readily or appropriately, they may perceive general practice have lesser role. I disagree with that. I think we've certainly got a role, but patients don't come in primarily saying I'm having trouble with my inhalants.
Where do you sit on the long-term health effects, particularly mental health effects of cannabis use?
It's complex. The research certainly suggests that those who are predisposed from a family history or other previous events for a psychotic event that may well trigger them into psychosis. I don't personally see a lot of that, and that may present probably more to emergency departments. But I do see a lot of harm from a productivity point of view, not just from an occupational thing, but productivity within the family unit, for example. Family member disengaging from family and just getting stoned in the corner. And often I find most substance use the triggers fall into 4 different categories. Sometimes it's for enjoyment or for social reasons, for pressures and things. Alcohol often fits into that. But often it's loneliness, boredom, or de-stressing. And cannabis particularly fits into those sort of categories where someone finishes work and wants to de-stress, or is lonely, and this is one way to bide the time, or is just bored. And again, a bit similar to loneliness itself.
But because we don't know what people's predispositions are necessarily, individuals won't necessarily know. There's really no safe usage of cannabis, is there?
That's the thought. There probably is a threshold where it certainly increases the risk. Like for most substances we use, there is a dose curve. There's lower risk, and if we look at alcohol, there's no safe alcohol either. But there's levels we're comfortable with as a society, and there's areas that, from a guideline point of view, and even beyond that, where society frowns upon people who are just getting drunk. So there is a dose response, and I think cannabis is very similar. Low dose is probably not going to cause much harm. For some individuals it may, and for higher dose and more frequent use, it's more likely to cause harms.
What are the reporting obligations on GPs in relation to patients that you're treating in relation to some of these addictions? I don't mean, reporting them to police. I'm interested in terms of reporting by way of statistical gathering and so on. How robust is the data that's coming through from GPs in terms of conditions? Or are GPs reluctant to say that they are treating people for illicit substances because that can trigger a criminal penalty consequence for the patient?
There isn't any mechanisms for broader statistical analysis of what's actually happening within general practice. There was a research study called the Beach Survey, which was a rolling survey of GPs. It was 181 time, but it was developed thousands of data inputs that gave an idea. We basically filled out a day's survey of exactly what we did for every patient. De-identified, that gave us a really rich picture, and that's to be indeed funded. Outside of that, then you've got secondary measures by looking at PBS prescribing data and stuff. So we then make assumptions of what's actually happening rather than things. When you've got, for example, the PBS writing to GPs about their prescribing, that's been variable in its impact. Sometimes it's been worded in a very sort of, here's some information, here's some ways of improving or optimising, here's benchmarking. A lot of the time, the wording has been a bit skewed towards being perceived as you're doing the wrong thing. And so that can either lead to a complete backlash, like I'm stopping altogether, which is not what we want. We still want GPs engaging with this, but we want to make sure it's appropriate prescribing around that. So there is some bit of education that could be improved, but often it's also these are very blunt instruments in analysing. I know of a colleague who was doing a lot of palliative care that was told he was prescribing too much morphine. He said, well, that's what I do. And so these instruments, even though, with the logical brain you think, well, this letter's for everyone and it obviously doesn't apply to me, there's still an emotional reaction of getting something that tells you, you're not doing the right thing. And so, but we don't have really good reporting to say exactly what's happening. It's there's probably a combination of system factors. There's no data input system that gathers information, and there's also a strong reluctance for probably the majority of GPs to share what's very because it's one-on-one data. Yeah.
Final question. How concerned are you about these potent novel opioids and the propensity of Australia to go down a path that North Americans are experiencing with mass opioid addiction?
Very concerned. We had, not just with the novel ones, we had fentanyl-laced heroin in Canada or North America a few years ago, and we've had a little bit of that in Australia, but it hasn't come across, thankfully. I can't explain why exactly we haven't followed suit. We usually follow suit fairly closely. The opioid crisis with prescription opioids, we had a milder version of that, but still a crisis. And these novel agents, synthetic opioids particularly, and synthetic other synthetic cannabinoids. There's a number of synthetic things actually are very, very potent, dangerous, and have less health benefits. The pros and cons are really swayed. And when they're laced, people don't know. Is there anything we should be putting in place that we don't have in place to protect the community? It's challenging with the market. The illicit market's hard to control. Certainly, the improvement of the availability of naloxone through community services, pharmacists and GPs prescribing it will help mitigate that. But I think it's not optimised. Still probably the minority of people who are exposed have something like naloxone. If you had a peanut allergy, most of us would have an EpiPen at home for an anaphylaxis. If you're using opioids, because of various usually stigma, you're not going to be exposing yourself to being judged to access that necessarily. So the uptake of that, but it's an important policy change. I think it's really brilliant. But there's way. I think we need to improve how accessible that is across the board.
Thanks, Dr. Quincy.
Monique.
Thank you. Really interesting. If we accept that the GPs are probably the best placed people to identify people with substance abuse issues in the community and to provide that first line of care, but that the current Medicare rebate model is not optimal for that, particularly with respect to the disincentive for longer consultations and chronic disease management, taking into account the fact that there's obviously alternative models for reimbursement through Medicare. What are your feelings about other members of an extended group within a clinical practice who could provide care as opposed to GPs?
Certainly there's a role. I mean, I use my terms a bit loosely sometimes. So there's the GP, myself, qualified as a general practitioner, and there's the general practice, and there's a clinical team as part of that. So, for example, in my clinic, where I'm in North Melbourne just here, I've got myself, I see the patient one-on-one, and then we'll often, particularly for opioid treatment, then my practice nurse will be doing a lot of the extra hands-on and also some of the counselling work around that and exploring. So that's only a two-person team. I see certainly some value in particularly GP clinics that have identified themselves as being a bit more engaged with this area. Of a mental health nurse would be fantastic. Or a psychologist, or someone who can help with that sort of counselling part, which would take the time burden away from the GP. Because most of my time, when I'm spending half an hour to 40 minutes with a patient who needs that time, a lot of it's to do with the behavioural change motivation, interviewing, the counselling skills, supporting them through that. Now, you can't ignore that. I can't just to prescribe and off you go. But it would allow me to start the ball rolling and say, well, I think you've got a big issue here. How about we schedule some time with whoever it may be, a mental health nurse, because I think you've got value for that. And we did have a colleague of mine was involved, and I wasn't involved at the time, but a number of years ago there was a little trial of mental health nurses coming into general practice, and it was well received. And then again, there was a trial funding and died. But I think certainly broadening the team within general practice. There's also, I think, an untapped potential we haven't looked at is not the retail pharmacist, but the clinical pharmacist embedded. Now, for the average GP who's probably got a few of these patients, the value for this AOD topic is probably minimal because they're not going to see enough. But there'll be value across other areas of health as well. Yes. I think that embedded, a GP, a practice nurse, a mental health nurse or other type of counselling service, and a pharmacist would make a great team. Yeah. And we retain the continuity of care. We retain within the practice. We're not fragmenting and making it geographically difficult to access, and it would be replicatable, provided workforce was there, into the rural areas as well, not just an urban area. It's something that works, but the practice is already there.
Yeah, that exactly. Yeah.
Yeah.
And presumably a bit more cost effective than having everyone looked after by a specialist in addiction medicine.
Yeah. And I think we know that primary care is very effective in terms of cost effectiveness for the health whole. $1 spent in primary care, is much cheaper and probably is an investment compared to other costs further down the track itself. So. A practice team is really, when I say GPs, often mean in my head myself with a team rather than myself as an individual.
Do you have any concerns about the fact we've talked about fragmentation of care and the inadequacies of data collection within the Australian healthcare system? Do you have concerns about the provision of services via telehealth? External to the PBS, and the extent to which that might subvert, I guess, best practice care of people with
no, telehealth per se, not so much, but the model is important. So if I look at one of my other roles is working for a clinic called Clean Slate Clinic. It's a telehealth alcohol withdrawal service that we mainly access patients access us who either have a GP who's not confident or unwilling to help with an alcohol withdrawal or not sure, or in areas where there isn't those services. So basically a lot of rural communities, there's no option. And there is a triaging around that. Now, part of this clinic's priorities is involving a GP. So pre-detox and assessment, there's a GP involvement and communication. Throughout and afterwards, there's involvement. So it's really a secondary sort of helping out with an aspect, but really handballing clinically back to the GP, saying, I've done the work, here's some resources. And this clinic's got a 12-month program of an alcohol withdrawal nurse providing counselling support to help people maintain not drinking over 12 months. That sort of model, I think, doesn't fragment care because it integrates general practice as part of it, whereas the sort of standalone cannabis prescribing or standalone other sort of single issue things, just dial a doc. I think they're a real risk to what we're looking for is optimising our health services and maximise the benefits it's already got, like you've just identified. Yeah. So the model, I think telehealth's great. It actually has increased care, access to care, but we need to be careful of the models around that and some sort of integration with the existing GP so that relationship isn't lost or subverted through someone else prescribing, if it is prescribing or treating in a way that's undermining that GP's role with the patient themselves.
Absolutely. Thank you.
Thanks, Anne.
I just have a quick question about the availability of GPs. How do you think we get more graduates to actually choose GP, to be a general practitioner? Yep. Over time, there's been changes to the way that they're looked at now as a specialty. However, it doesn't seem to have shifted the number of people who are choosing to be a general practitioner. So it used to be about 75%. Now it's averaging somewhere around 12 or 14%. So a lot of these inavailabilities for services, and the reason why Dr. Anandra was talking about specialist clinics is because if you are suffering, it's probably not the right word, but if you have an addiction that needs to be treated and you have a bad day, so you're partway through your treatment and you've had some sort of crisis that means you're having a bad day, you need to be able to come and talk to someone as soon as possible.
Yes.
To keep that treatment going, as in any issue also with mental health. And it's hard to get into a GP.
So you've got a few aspects of that statement there. I'll address just it's hard to get to a GP, and particularly for that sort of crisis or that urgent need. I know of a number of us who, despite having maybe booked up for the day, there's no appointments available on paper. If I've got a patient who I know is on treatment who's got some sort of crisis, we will fit them in. We'll even make a phone call to organise that if coming in physically is going to be too disruptive for anyone. So there is some flex, but that saturates. You can't do that for every single person, and hopefully we just, there is a little bit of prioritisation of who needs it and who doesn't, and try and schedule around that. But you're right, there is a lack of really good workflow coming through to support the increasing needs of our population. One area that I think this is low-hanging fruit, and I'm surprised it hasn't come back. A number of years ago, there was a program called the PGPPP program. It was a part of a doctor's residency year, so the intern and their rotations, they go through hospital, through different, you might do a bit of vascular surgery, and a bit of psychiatry, and a bit of this and a bit of that, before you decide which pathway you want to go down. General practice was part of that. So you could do a rotation into general practice, test the waters, try before you buy type of thing, and not just to get people into general practice, but if I was going to be a neurologist the whole time, I now know what general practice is actually like. And so I can actually relate to GPs much more effectively and get a better referral pathway, and that for the patient's journey is actually more effective because I understand general practice rather than making assumptions. So the majority of graduates these days never get, the only time they're in a GP is if they're sick. And 20-year-olds don't get sick very often. So most early graduates going through their medical training have zero experience of general practice, particularly from a work point, that sitting in the office rather than sitting in the patient chair. And so there's no wonder, with years of exposure of hospital-based medicine, which will have its own biases and its own ideas of what general practice is, even those that were sort of thinking about general practice for the years and years of being stuck to some extent because the system won't allow them to move anywhere else in the hospital system, they're going to stay there. And I think that loss of that program, I don't know, I haven't got the information of how much it cost, but that would be a big improvement in both how general practice is perceived within the medical community, but also the relationship of all graduates with general practice. And I've got a number of colleagues that went through that program, and they said that was the pivotal bit, doing 6 months or whatever it was of general practice. I actually loved it because I then used all my skill set. I used every bit of it. The medical training that I had, I actually could see a bit of surgery, a bit of psychiatry, a bit of medicine, a bit of chronic disease, a bit of acute medicine, peds, adults. It was all there, and I felt like I was a real doctor. Whereas when I was doing my thing, I felt like I was a real vascular surgeon's assistant, which is important, but it doesn't give anywhere experience. So if we're looking at ways of trying to improve things, there's a number of things that have already been tried, and there's increased medical student placements, which hopefully was going to funnel things through. It doesn't seem to be working at the moment. But I think that's one area that the committee here may want to consider, is just ways of trying to integrate general practice as part of training. I know the universities will have variable amount of uptake within general practice placements, and that's the important part, but certainly that post-vocational, early pre-vocational training is a gap that we've got at the moment. There's an opportunity there.
And have you made, have you got a view, have you got some sort of, have you gone to the Health Minister and said, this is what this is what will help more GPs? Get more GPs?
Not personally.
Well, no, but the college.
Actually, I'm not sure.
Can you take that on notice? Because I'd be interested to know whether some of those ideas have been put forward.
And if not, if we've missed that opportunity so far, I'll be certainly advocating for it to be an area. I know it's been discussed a lot. I'm not sure whether it's actually gone into that Health Minister advocacy.
Because we're staring down the barrel in the next 10 years of very many of you and your colleagues retiring. So we've had a number of years of under 20%.
I'm hoping I'm not retiring yet, but I'll get there. Yes,
but in 10 years, 15 years, you may want to actually work part-time and ease yourself into retirement and not retire like my doctor did at 84. So, but so that's something we need to think about as in this context as well. Thank you very much. Thanks, Chair.
Thank you. Just a couple more questions. And, I do think that the AOD area is a very complex one, and I do think if we have to rely on our GP workforce to do a lot of the heavy lifting in this regard. So I think the rebate issue is a very valid one, because they are very complex patients.
I can just add one thing before, sorry to interrupt, but the rebate also, apart from being financially, that's the main thing, but also sends a signal that this is an important area. So it may not have to be a rebate that makes it financially really worthwhile. Now this is all I'm going to do. It just sends a signal that this is actually important. So it may not be a rebate, but there could be some sort of other incentivation.
Well,
At the moment, it's ignored.
Well, I think you're right. We do need to give general practitioners an incentive to see these patients who already have enough barriers to getting adequate care. And I think we certainly heard yesterday that there was a struggle to encourage people to get into the authorised methadone prescribing, for example. And it is a very complex issue. But I just want to go a step back, just talking about your own practice. If you see someone that you think has a problem with alcohol, how do you manage that? What would you do?
Well, I can easily speak because this happens to me multiple times a week, and partly because I've
Multiple times a week?
A few times a week. I've got a new patient coming to see me for alcohol problems. This has changed enormously pre-2020. It might be once a month, a bit less. And I'm a GP with a reputation around this as well, so I'm going to be a bit more patient-selected, like me. But COVID lockdown flushed out people who had been drinking and now no one could hide it because the family were around. So that those ones sort of almost had to access some treatment. And then the prolonged lockdowns also gave people an opportunity to drink and then continue drinking and then found they couldn't stop. So that dynamic changed. So there's certainly, I think, a lot more people presenting. Plus the acceptance, well, I won't say it's accepted yet, but the societal viewpoint around alcohol dependence has changed. We've got alcohol-free months, 3 or 4 per year. There's alcohol-free bars. There's one in Brunswick here that's in a cocktail bar that's just alcohol-free things. That didn't exist 5 years ago. So there is a societal change around acceptance around being alcohol-free, or at least reduced alcohol. But I won't say it's easy. It's certainly, there's a lot of improvement in how our society perceives alcohol. And I heard Dan talking earlier about, the comparison between our public messaging around gambling health versus alcohol. It's quite different. And so there's some opportunities for us to improve how that's perceived over time. But what do I do when a patient comes to see me? I insist with my reception staff that a new patient has a double appointment, so I've got some time at least just to get the lay of the land.
So that gives you, what, 40 minutes or something?
That gives me up to 40 minutes, and so probably the average would be about 30, 35 minutes for these sort of patients. Part of it's assessing their alcohol use, so if someone's coming in saying, I need help, part of it's only assessing how much they're drinking, what the impacts of it, why they're there, what's led them to make the decision to seek help, and really acknowledging that, and for me, really acknowledging that I'm certain at this point, even though I've never met them before, because everyone's got the same story. It's taken them months to years to realise they've got a problem, acknowledge it themselves, and then sometimes even longer to actually access help. So it's really affirming that the fact that they're here, they've actually done most of the treatment. Because most of the treatment actually missed out, actually getting in front of someone. A lot of people are actually not accessing services because of the embarrassment and shame around that. So to get to see me, well done, here's what we can do. And it depends on what their goals are and what the harms are. So some will need an alcohol withdrawal, so stop suddenly, medicate that week so they're safe. Most patients can be done in primary care. Some need inpatient or other more service, because of the higher risk. But outside of the withdrawal, and that's important in that first consultation, is to set up ongoing care. So part of it may be medications like craving reduction medications, but a lot of it's to do with behaviour change and then helping them address their childhood trauma or their marital issues or the physical issues they're dealing with or how stressful work is and the consequences that may have led to the alcohol use, either starting or getting embedded in their lives. And that's really where the work is. The front end, if there's a withdrawal, that's a bit of exciting medicine, but lasts a week. But the long tail's really where it's important.
And do they require psychological assessment?
Yes, so I've done some psychological training myself, so I can do a bit of that myself. I see overall patients who do well after stopping alcohol, or at least if they're looking to have low risk drinking, the ones that do better have some medication on board to help reduce cravings. They have engagement with groups like Smart Recovery, some peer groups. AA is another version, although most of my patients shy away from AA because it's more black and white and There's a spiritual aspect that a lot don't relate to. But for some, it works well. So some sort of peer network group, that can be very helpful, as well as, and this takes some time, addressing some of those psychological, either consequences of alcohol use or other substances, or predisposing things. And there's often there's some underlying, often childhood experiences that have been suppressed, and alcohol helps that suppressing. And if you're going to stop those emotions rise to the surface, then we have to help people have strategies to manage those. Otherwise, they're going to relapse.
Good.
So that's important there.
All right. Thank you. I don't really have any other questions. Nope. Good. All right. Well, thank you very much for giving us your time today. If you've been asked to provide any additional information, please forward it to the Secretariat by no later than Tuesday the 12th of November 2024. You'll be sent a transcript of your evidence, and you'll have an opportunity to request corrections to any transcription errors. So thank you very much.
Thank you.
Good.
What's that?
Thank you. I now call witnesses from Windana to give evidence today. And thank you very much for giving us your time today. We did visit yesterday, but Dr. Ryan and Mr. Lisa weren't present with us, so they will be hearing for the first time about Windana. For the Hansard record, before giving evidence, could you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. Giving false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a short opening statement before we proceed to discussion, and thanks once again for coming.
Let's go. Okay. Well, thank you again for having us. My name is Adam Miller, and I'm the Chief Communications Officer at Windana. Did you want to?
Mark O'Brien, Chief Operating Officer for Windana.
So I'll deliver a little bit of an opening statement, set the scene a bit, and then we can take it from there, I guess. So yes, thank you again for letting us or having us here to present at today's hearing, and for those of you who came to visit Windana yesterday. As you were leaving, you asked for a wish list, and so that's what we're pleased to offer you today. There's no denying the significant impacts of alcohol and other drugs in Australia as an organisation that provides services for adults and young people experiencing alcohol and other drug harms, family violence, mental health challenges, and social disadvantage. We see it every day. From a young person, let's call them Sam, who has experienced more trauma in their lives than most people in this room will face in a lifetime. Sam has turned to alcohol to numb the pain and now is skipping school. To an adult who we'll call Pat, whose opioid use stemming from an undiagnosed mental health issue has led them to lose their job and now they're sleeping rough. Pat wants to turn their life around but can't afford to travel to one of the fewer than 7% of Australian GPs who offer opioid replacement therapies. Now, obviously, these are two hypothetical examples, but they do demonstrate a critical reality, and that is that problematic alcohol and other drug use does not happen in a vacuum. We all know this, that's why we're here today. And indeed, on the webpage for this very inquiry, it states the ultimate aim is to improve coordination and cooperation of health and other relevant sectors to support the implementation of effective, equitable, and innovative policy responses. Now, this requires a huge shift, and part of this shift can be driven by the data the federal government mandates service providers like us to collect. A shift from outputs to outcomes. For example, from capturing whether someone was referred to a housing agency to capturing whether their housing security has improved. To do this, data collection at all levels needs to include a meaningful focus on the social determinants of health. It's often said that if it's not written down, it didn't happen. Take a quick look at the data that service providers are mandated to collect in the alcohol, tobacco, and other drug service database, and you'll see that what we're being asked to capture primarily relates to demographic data and outputs. How many sessions, who ran the sessions, and so forth. There is little, if anything, about outcomes, about what a person needs to be able to meet their recovery goals. This is what matters, yet it's not captured in federal government mandated data fields. So let's think about Pat from the example earlier. Pat made it to residential rehab and has completed their program in 9 months. Is it the number of days Pat was in rehab that determines their long-term success? Or is it whether Pat's housing situation has improved? What about their opportunities for employment? It's the outcomes that matter, and that's what we should be counting. Yeah, as I said before, there are little, if any, mandated fields collecting this. This approach is fundamental to our case management approach at Windana, but it's not directly funded by any level of government. So if it's not written down, did it happen? Do our funders care? If the federal government includes outcomes in the data it wants captured, then by extension and by design, providers like us are funded to do this work. And then things start to shift. A focus on outcomes and the social determinants can lead to a minimum 5-year funding contracts from PHNs to provide financial and operational security for AOD providers and staff, and so the clients can access services without fear that those services will close at the whim of short-term funding cycles. Longer-term funding allows the required focus on outcomes. It can lead to more needs-based funding decisions. For example, social connection after a residential program is vital to anyone's recovery, and we spoke a bit about that yesterday. Yet there are no programs funded for this in an ongoing way. It can unlock the potential of nurse practitioners and remove the transactional bottleneck of the current GP-centric approach. Nurse practitioners are embedded in our residential withdrawal model and see our clients daily throughout their withdrawal. They are best placed to offer outcomes-based care, yet they have limited access to the PBS and the MBS. Stigma is a barrier that prevents help-seeking behaviour. A national campaign would help dismantle these barriers and lead to increased opportunities for people to access services they need to change their lives. And let's consider system navigation and sectors working together. If services were funded based on outcomes rather than throughput, it follows that our fragmented system would work better together because it's funded by the government to do so. A focus on meaningful outcomes means our work changes and saves lives. Imagine if our funding models, our data collection, and our service systems were more focused on these areas as well. It was written down and it happened because we care. Thank you, and we welcome your questions.
Thanks. I might start with you, Monique. Would you like to?
Thank you. How do we best capture those outcomes? I guess sometimes it's a bit hard to know what questions to ask and what data we should be doing. And not only what questions should we be asking, but what's the best means of storing that data and presenting it to the government or to other funding bodies?
So most of the data is one-off. If you look at the primary mental health care database, the AD database, you ask a K10, so the mental health screening tool for suicidality or mental health risks, and then you'll ask the same thing again. In Victoria, the state government-funded bodies, the Victoria Auditor General report 3 years ago was quite critical of the rollout that led to the government saying get a system and buy any system, and the sector, predominantly not-for-profits, went out to market and just bought systems for the purpose of uploading data. That same data set, in our case, VADC AHW, it goes to AHW ultimately, but most of it's one-off, and we're not looking at longitudinal. So Adam made the comment about social determinants, and whether you want to talk about Maslow's hierarchy or whatever. In AOD, there's this concept of social recovery capital, social connection, housing, employment, education, family. We actually don't ask any of those questions. And the fragmented funding model, if you go into a withdrawal unit, the person who refers you there doesn't pick you up afterwards as a business model here in Victoria. A little bit different in other states, but it's not much better. If you go through a rehabilitation facility, you leave that, you're not picked up by your previous provider either. You've got to re-nominate to get back into the system. So each time it's segmented. And so if you look at the basic GP care model, or as a couple of you guys as specialist practitioners, you get a referral from the GP you see, and then once or twice you send back, and the GP is meant to have that longitudinal journey. And so you could strip the data out of there and show an improvement over time, but our data doesn't seek that. It wants to know what your qual was, what you did for how long, but it actually doesn't ask you what you achieved. So it's changing some of those fundamental questions, and no one's really doing it that well internationally. There's a thing out of the States called the Vulnerability Index, which came out of a guy called Jim O'Connell, who set up the Boston Healthcare Group, and he looked at homelessness people, and he found some really simple data points. Now, for that group, he was looking at obesity, diabetes, hypertension, hypothermia, and something else. So really health-centric, but if you had 3 of the 5, the risk of death was quite high. If you intervened against those 3, diabetes and hypertension quite easily, then you'll start to see some shift and some improvements. So it's really about asking the right questions, and I think some of the right questions are there already. It's Maslow's hierarchy, social determinants.
But presumably also having various ways of collecting that data, because as you said, people will often presumably go from one spot to another, and recidivism won't be captured and things.
And we can't use a unique identifier key, so we can't pick up a Medicare card and have it translate across the system. So as you feed the data up, they're called PKI keys, you can see date of birth and a few other identifiers are unique, but it doesn't start to be seen until it gets to government. So it's not seen by independent providers. In the Northern Territory, your healthcare record in Alice Springs can be seen by the person in Darwin. And it's a smaller territory, but we haven't got that here in Victoria, as you know. You go from Epworth to the Alfred to Monash, and it's a different file every time.
Yeah.
So here we're legislating to make the mental health system talk better, but it's still not quite there. My health record, I thought, might have been helpful, but it really hasn't gotten there either. And we'll never have access to that. We don't have access to any of that because we're outside of community health funding.
Yeah, I was going to ask about that. What about private health insurers? Does that does the presence or absence of anyone having I've got no words to having private health insurance change the data collection at all?
So for us, we're state, federal funding. Our clients, we're not fully funded to run the service, so we ask for 78% of your Centrelink, which is $600 a fortnight. Private health providers provide that amount, and we've never been required to provide data back to them.
Okay, thank you.
Julian, do you have any
I just wanted to take your recommendation 2 in your submission and just explain what the present position is in relation to the funding of residential rehabilitation beds and what you're looking to change there. Just to go back to
Minimum number of residential beds.
Okay.
Per capita.
What's it cost to run a facility is the question that is the best answer. So we get funded this thing in Victoria, it's called the Drug Treatment Activity Unit. You get 16 DTAUs on admission, which works out at $954 for a DTAU, which is, say, $15,000. That's to admit a bed. To run a 24/7 facility, you need 2 staff per shift. and 2 staff per shift annualised is about 1.3 mil just for the staffing amount, and you're not looking at doctors or psychologists or psychiatrists or the cook or etc. So we've basically got to the point where you need to get close to 40 people using the DTAU envelope here in Victoria to make it work. Therapeutic communities have been adopted around the world because the idea is that you use this thing called the community as method model, and you basically take the norming and storming approach from people within the residential facility to make sure that certain behaviours don't occur. In Victoria, 30% of our clients are meant to be forensic, and that comes with challenges because people who have been in and through the forensic system often present slightly differently because they're coming with a different trauma background.
By forensic, you mean people who've been engaged in the criminal justice system and effectively are put in your facility as part of being engaged in the criminal justice system? Is that's...
Yeah, they'll...
What we might have at one time called sectioned patients, or not quite?
They're not sectioned. Community corrections orders or they'll be awaiting trial, or they'll be awaiting sentencing.
Right.
And so people will... So there's a criminal note sitting there with whichever legal system, yeah. And so really it's about what's the right amount to make a facility viable. And so if you look at a regional hospital, if they're not doing a certain amount of theatre days, then it's really a non-viable. They're just a medical holding space. And it's the same sort of stuff for us. What's the right amount of money, which is basically based on the head count or throughput to work out.
And your point about geography, are you effectively saying that there's not enough in the capital cities, particularly in Melbourne, or are you saying that there needs to be more in other places? What are you...
We've got a spot in...
saying?
We've got a 30-bed unit in Geelong, on the north side of Geelong. We've got a 20-bed unit in Ballarat, which is too small. Financially, it requires propping up. State government's announced that they'll run a facility in Mildura. I argue that the population base isn't big enough for what they're proposing. But majority of people actually don't want to do rehab around the corner from where some of their things are occurring. So they actually want to go somewhere else. But going back to that social determinants bit, we've got to do the work to make sure that they're connected into their social infrastructure because they've got to find a new social group. The previous social group may have been traumatising, or it may have been drug seeking, or it may have been problematic. And so we've kind of got to do what you do with your teenagers, where you go, what are you good at? What do you like? How do we expose you to some of that? And then gently allow them to attend. Significant proportion of people that attend residential treatments have got anxiety and depression. So social anxiety is a massive reason for people using drugs. So you can work through that, but now you've got to connect them to somewhere. So regional by all means, but you've got to have the right amount of beds in place, otherwise it's not really financially viable.
And this one comes back to that question of equity that was sort of sitting pretty high level in the inquiry as well, because, and I think we called out in there sort of the number of beds per capita, so low in Victoria, yet it's so much higher in others. If we're looking for equity, then that's one way to kind of bring that sort of across the country, rather than leaving it to the states to decide.
I'm sorry I didn't get to come and see your facilities yesterday with the rest of the committee. Can I ask you just briefly, given your long experience in this area, what are the most successful ways of rehabilitating somebody and ensuring they don't come back to see you? Change them up. What does your experience suggest in that regard?
Oh, my advice is social connection. Monday afternoon at the facility that we're at yesterday, there's a group of about 15 people. The man who's been facilitating that as a volunteer for a long period of time and now he's on salary, I asked him a question about, because I want to try to do that elsewhere, but it's not funded. And the smile on his face as he went, we used to, and it's this, and if we do that, and then I reach out, and it's really social connection. And it's...
So how do you manufacture that? So,
yeah, your sport...
My question to you.
Your art group, your theatre group. Kids in year 9 in private schools here in Victoria, and I'm sure it's happening elsewhere, that developmental phase of 14 to 15-year-olds where they start sexual identity and identity formation in general. At that point in time, a lot of schools are getting them to do outdoor education and rock climbing and going to theatre and trying plays. And at that point in time, they get to understand who they are or explore their social identity. And that's kind of what rehab's trying to do at the same time. But you've got to leverage someone in there. You don't take your 5-year-old to its first soccer training session, drop them off and not pick them up and go, how was it? And show some enjoyment and enthusiasm and make sure they go back next week. we've got to do the same for these clients because of the social anxiety. If you don't step them in, hold their hand metaphorically for that little bit, and then validate their existence in society, it's pretty easy to go back to previous drug-seeking patterns. And if you look at the trauma pathway that a bunch of people have been on, if you look at the social disadvantage that they've experienced in the first place, it's pretty easy to see why some people use drugs as a way of escaping their reality. So we need to think differently. So someone mentioned yesterday service connection or service navigation, and that's pretty much the...
And last question in that regard. If you're looking at facilities that are a long way from where people have, where they live and where there are bad connections, as it were, how do you then take them from the environment that may be, quite some distance from where they live and take them back into the environment and connect them to the environment where they've been living with good connections, or do you just move them out of that environment altogether longer term? What's the reality there?
So no one's been sectioned, so it's choice and control, and all you can do is influence. And as you, in our case management model, it's what are you doing about your housing pathway, your employment pathway, your education pathway, and what can we do to enable that? But we can't control some of those externals. So it's about trying to support people to understand why they're important.
Thank you.
Sure.
Firstly, I think that's the best list of recommendations I've heard over the last 2 days, so well done. They were really concrete, and those are deliverables that we can actually ponder on and potentially work on. Just with respect to, I guess, what we're talking about, social prescribing, it's not a new concept, and it's just interesting that we're hearing this in this space. It's something that is absolutely being looked at by countries like the UK, but here in Australia, particularly for elderly, vulnerable elderly. So one of the keys there is linking people in to local government, because local government is very much at the coalface. They've got the ear to the ground. They fund a whole range of initiatives. And I was just wondering, is there a role for, say, the Commonwealth to provide, as part of that block funding, better connections between this sector and local government to enable, to kind of streamline or fast track that social prescribing that you talked about in rehab?
I think the primary health networks could look at that. Where we were yesterday, just down the road, the Alma Road Community Centre has got the only statewide parrot group that meet once a month.
What's that?
People who collect parrots, and they've got this like.
Oh, you mean?
Yeah.
So I thought it was an acronym for something.
It's the most niche. It's the most niche thing I've heard in my life. And yet there's 25 people who rock up there once a month to discuss parrots. So everyone's got their little peccadillo. One of us went in. I was obviously there with another person, but. The PHN, we mentioned 5 years. I need, obviously every primary health network, all 31, get to make their own decisions, but the funding is for 2 years. You've got to give up your job to go and work for the PHN for 2 years, and I'm pretty sure most people don't want to do that. So the risk is you end up getting people early in career. And this is why social prescribing...
running the PHNs, you mean?
No, what they subcontract people to do. So the PHN in Victoria will subcontract us to deliver something for a period of time, but it's often 2 years at the most. And so you've got to get someone, from the social prescribing perspective, someone who knows the randomness of the parrot group. Like, that's the person that you really want advocating for you when you've stepped out of a chaotic space. They want to know who you are and what we're going to support you with. But the reality is, when you provide short-term contracted funding, you don't get those people. You get people really early in career.
Right.
And so that's the challenge for social prescribing. If you went for a longer funding period, like if you go for a 3-year envelope or a 4-year envelope, then perhaps you can start to get better integrity within the workforce.
I think 5 years is a good one that you suggested.
You could be a dead parrot.
So just to close that discussion off, considering funding specifically for linkages into local community, perhaps using local government would be good, because local government actually do, at least in my electorate, they do fund initiatives for this very vulnerable group of people who fall through the cracks otherwise. The other thing was, what are the challenges in dealing with the PHNs? You need to be frank. This is the forum to be frank.
But it will be recorded on hand.
And it will be recorded on Hansard.
We could go.
Oh, we could go in
We
camera.
go in camera, that's true.
Yeah, I know. Look, I worked at the Northwest PHN for 9 months. My title was Director of Mental Health. I had several headspaces under the remit. We did some suicide money, which was a state, federal combined thing, and I had some alcohol intervention. What came down the pipeline, from what I could see, there was a sort of broad remit, but there was a short-term funding envelope. So it wasn't so much that, it was more what was the directive, what was the legislation or the regulation or government at the time suggesting. By the time the PHN could interpret what that meant on the ground, you've lost 6 months, so you're down to 2.5 year window. You go to market, you're down to 2.25, and so you're basically tendering for a 2-year product.
I've heard this feedback before.
So I think
in my
that's the
community.
challenge.
Okay,
When I
so
think about-
it's just a very long lag time from when the Commonwealth says, right, here's the money, go and disperse it, to by the time they actually get their act together and do it.
Yeah, so I think that's where
Why is that so hard? I mean, you are already in the community, you know what to do. Why can't the PHNs just write a check and say, go and deal with this? This is the outcomes we want, go and fix it. Why does it have to be so command and control?
I think they're seeking a competitive tendering environment to make sure that you've got a product that reflects what the catchment area or the data suggesting is needed.
But they surely don't have the expertise, you have the expertise.
I think what you're saying is there's an added layer of bureaucracy here that is costs money, delays the process, doesn't improve outcomes.
So what sort of instruction would the Commonwealth or the department need, well, the Minister would need to give if we were to provide 5-year block funding, just kind of totally crunch that lag time between announcement and delivery to the stakeholders?
I think if they picked up some of the reviews of products that were tested across the other 30 PHNs and actually tested that in the area instead. Terrible segue, but for those of you who've worked in tertiary hospitals, every time we build a hospital in Australia and there's a mistake, we don't get to read the report, but in America they publish it. So when Adelaide built its hospital and it was $1 billion blowout, what went wrong and what was said to the architects and the procurers of the contract to make sure it didn't occur again. I've worked in a hospital where the ceiling was too low for the ambulances to come in. I've worked in a hospital where there was insufficient stories for CSSD. I've worked in a hospital where the shut-off valves for intensive care, you had to go into the ceiling to get to them. And the designers know that, and the reports get written, but you never see it. And I think it's kind of the same with some of the PHN commentary. We've got things that have been tested in other states, and someone somewhere in the middle says that might not work. Everyone's speaking the same type of language, and we've got the same broader healthcare system, so I'm not sure why we couldn't try and pick that up and try it again. So I think the initial intent of the PHNs to test new things, new products, and see what works made sense, but it looks like they're still trying to test new things. And
So we don't have a sense of what best practice looks like, and we have no mechanism to disseminate that best practice.
And we've got people in the middle who, we had a particular thing that we were asked to roll out within 15 months. If we hadn't have done it in the way we did, we weren't going to get no one wants to release a building to a drug and alcohol agency, firstly, which is kind of understandable. But we were never going to procure property in that period of time. But the way they wrote the tender, there was an assumption that you'd be able to procure a new property. Landlords don't want to give you a 1-month lease on a $250,000 outflow building, regardless of whether it's Fed money behind it. And no one wants to come across for such a brief period of time as a staff member. So it's the brevity of the contract, but also what are we learning from previous products that have been tested rather than trying to reinvent the wheel? And there's a couple of things that we're doing here in Victoria that actually the PHN are funding that the state already funds, and it's meant to be different. And so there are people within the PHNs who haven't got the experience to understand what the state government's funding to create a different product in the market.
So to improve the coordination between federal, state, okay, yeah. I don't have any more questions, thank you.
Ms. Stanley.
No, I don't have any questions. I won't ask any hard questions about the PHN, but can I just thank you and your staff for yesterday? It was really, really enjoyable, and maybe enjoyable is the wrong word, but really helpful. So thank you so much.
Yeah. Thanks, Anne. I've got a couple of questions, and once again, thank you so much for yesterday and for giving us your time today. The social determinants of health we hear all the time. It rolls off the tongue very nicely. But the problem we have now is that we know that your clientele comes with all those problems associated with the social determinants of health. How can we best invest in the AOD sector that makes the journey better in terms of alleviating the problems of the social determinants of health? And are we basing what we want to do on false assumptions? And I'll say that and preface it by saying, it seems to me in your sector, there are some people that are going to get better, some people that are going to struggle on no matter what, and some people are just going to keep the revolving door going. And shouldn't we just accept that and stop looking for magic solutions? Would you like to comment on that?
Oh, no, nice provocative statement.
It wasn't deliberately provocative. I was just interested in your answers.
That's because you've been so helpful. And
Yeah, no, I really respect the way you framed it. And you kind of did thirds. And the
Well, I don't
data's
know
been
if it's
different.
that.
It is. It is. There's a third who are going to fail. Is it because of institutional trauma? I don't know. There's a third who just recover with us doing nothing, which I'd prefer that not to have been on the record. And there's a third that we probably make a difference with. If you look at the economic analysis behind all of these things, like if you don't finish year 10, what is it, $4 million it'll cost you by the time you die at 63 or whatever. If you are in child protection or correction by the age of whatever, you'll cost X. Mental health placement leads to Y. Service Australia or Centrelink used to have some social workers who would go into a heap of different agencies once a week. Doesn't happen anymore. I think it's really dependent upon whoever your GM is in whatever state you're in as to whether that happens.
Yeah.
But that'd make a difference. So on King Street, I had a previous job managing a youth homelessness service in the city on King Street. Front yard
In
youth
Newtown?
services. Pardon?
In Newtown or Kings
No,
Street?
just here, yeah. Melbourne City Mission, which is the homeless service, runs this product called Front Yard Youth Services. We had Service Australia come in a couple of days a week pre-COVID. And so the clients who are there who are homeless but are actually interfacing with corrections and a number of other things can get their Centrelink tidied up. It makes a massive difference. Because if you haven't got a physical locale, it's pretty hard to get your Centrelink sorted. We also had a mental health team coming in. We also had, and so this sort of one-stop shop, and it's not uncommon in adolescence, it happens in a few different spots. It doesn't happen with us because of segmented funding, but also because I think the mentality of a number of organisations is you need to come to our building so we can meet our targets to achieve our funding contract. But actually, if you chucked someone from us and someone from someone else and someone from someone else into the one spot, and in some ways it's what a really experienced medical consultant kind of does. You've rocked up with gut pain, you've worked out that you've got problematic liver, but you fix the hypertension, then you have a look at the renal issues as well, and then you make a referral onto an endocrinologist because basically that was the problem. And in our context, I don't think we've talked about sobriety or abstinence at all. We've talked about social connection as the way to address some of the alcohol issues. And most of what we keep talking about is probably anxiety, depression, or intergenerational trauma. And so if we can do something about that. And so I don't want to say one-stop shop, but there's something about, I think someone mentioned yesterday, there was an intergovernmental committee pre-COVID here in Victoria. There was some good stuff from that. There's also a thing called MACNI. I don't know if, no. MACNI was brought out in about 2010, 12 here in Victoria, Multiple and Complex Needs Initiative, and it said that if you can bring a client to the panel with mental health, intellectual disability, or drug and alcohol, 2 of the 3 boxes need to be ticked. People from different services will get together and come up with a deliberate plan to try and address what this person needs. City of Melbourne hosts a session with managers once a week, and those complex people who you see sleeping rough, they'll try and unpack who's the right person to work with them today. And so you'll get someone from the alert team at St Vincent's, you'll get someone from Centrelink, you'll get someone from the street outreach team. Go and have a chat with that person who's normally complex. Is it mental health? Is it whatever? And try and come up with a decent plan to move them out of the vulnerable space they're in. So it's actually skilled professionals trying to advocate for someone to get through the system, and that's the 30%, and maybe the other 30%. So I think I can do 60% of the work.
Well, I think Adam mentioned yesterday that the biggest problem you have is getting people housing once they're through your program.
Yeah, we've got some good relationships with a number of providers, but they've got no stock. So it's nothing different to us to anyone else.
So if we could improve housing,
Yes, if you could do that, that'd be great.
maybe there's a difference. Yeah. And what about things like health assessments? I'm just thinking one of the issues for many of the homeless people with drug and alcohol problems that they cured during the Sydney Olympics was by giving them housing and health assessments.
Building their acumen to understand the long-term benefit of a health service. Just up the road from us on Brunswick Street is CoHealth's community health clinic.
Yeah.
Next to that is St Mary's House of Welcome, which do stuff as well. On Johnson Street is Inner Space. It's CoHealth. It's our local community health here in the city's catchment area. They've got doctors and a few other people in there. Actually getting people who are vulnerable to understand that. We all know that that group of males who don't look after their drug and alcohol issue are probably going to have a stroke or a heart attack or diabetes. Most of them, it's not relevant until it occurs. So if you're in chaos, I mean, from a mental health perspective, actually having a vanity cabinet to put your tablets in is probably the biggest thing that's going to address your mental health issues. So housing is important. But secondly, having a regular prescriber is the next bit. And then having a healthcare service who rings you up the day after you didn't attend. So St Vincent's Hospital a while back had a program where they were getting their infectious disease team to ring someone up and then almost send a taxi out to pick them up if they didn't attend, because they knew they were probably going to take up an ICU or an A&E bed if they didn't do it. So there's something about that really small population group. But it was Michelle's comment before, what's local council's role and what's community health's role in helping and enabling that? That's a gap for us.
Good.
Can I just add something?
Of course.
We talked yesterday about the housing, and I mentioned that there was a program that the Vic government had specifically for this really complex, marginalised group of people. I found my notes. This was advice I got from Launch Housing. This is called a permanent supportive housing model. It's like an SRS, but it's got a concierge, and there's a. I don't know if you're familiar with this, but maybe you might be. There's a place, Common Ground in Elizabeth Street in the city. She mentioned to me that this was built by Grollo at cost 15 years ago, and it has a 24-hour concierge service. Do we need sort of housing that looks a bit like that, with wraparound services, concierge, that's a little bit more high intensity than, a social model, public housing model?
So as you go up towards Peter Mac, a few hundred metres before that on the right-hand side, that's where the building is. Built by Grollo. Home Ground, Hanover, Salvos, there was a fourth one. They basically looked at the most vulnerable cohort in the city, 115 people were placed, but at that point in time they didn't do the concierge. They actually put people in the building and didn't give them any case management support. We've got access to 9 properties through Launch, through Fed money, transitional housing support. People can stay there for up to 12 months, so that's helpful for some. We've also got a bunch of people who want to live in a property by themselves, and there's a re-education piece that's needed because that's not viable. On a Centrelink, you guys know the vacancy rate's less than 1%. On a Centrelink allowance, that's not feasible. People actually have to cohabit. So there's a bit of a social housing education piece there. Because whilst there's a stack of single properties, it's probably the worst thing you can do for some of our clients, cohabiting. In Victoria, the pubs and etc. used to have the single man accommodation upstairs. They went a long time ago. So some of that stock, the rooming house thing, which was disgusting, needed to go. But actually there's a bit of a place for it too if it's supported.
So you're saying single housing doesn't work because there's no supervision or
Social isolation is probably the biggest thing, and the amount of our clients who don't know how to budget, cook, maintain, and it's because of how they were raised.
Good.
So more scope for supported housing. Yeah, okay.
Good. Any other questions? No. Good. Well, look, thank you very much for yesterday, and thank you for your evidence today. It's been really important discussion and food for thought for us, and we hope to use your evidence to inform policy. If you've been asked to provide any additional information, please forward it to the Secretariat no later than Tuesday the 12th of November 2024. You'll be sent a transcript of your evidence, and we'll have an opportunity to request corrections to any transcription errors. And thank you once again for coming. Thank you. And thank you for your team for coming as well. To now just suspend the meeting, and we'll reconvene at 12:45. We open this public hearing being held at the Mantra on Russell of the House Standing Committee on Health, Aged Care and Sport for the inquiry into health impacts of alcohol and other drugs in Australia. In accordance with the committee's resolutions of the 4th of August 2022, this hearing will be broadcast on the Parliament's website, and the proof and official transcripts of the proceedings will be published on the Parliament's website. I now welcome witnesses for the Centre for Alcohol Policy Research from La Trobe University to give evidence today. For the Hansard record, before giving evidence, would you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a short opening statement before we proceed to discussion. And once again, thanks for coming.
No worries. Thanks for inviting us. Anyway, we'd like to acknowledge that the land that we're on today is the land of the Wurundjeri people of the Kulin Nation. My name's Scott Wilson. I'm an Aboriginal person from Darwin originally. I'm the Chief Executive Officer for the Aboriginal Drug and Alcohol Council, which is based in Adelaide. And with me is Professor Kylie Lee, and we're both connected to the Centre for Alcohol Policy Research at La Trobe University. So, do you want to...
Yeah, so I'm Kylie. I'm a non-Indigenous researcher, also from Darwin, although I now live here in Naarm. And at the Centre for Alcohol Policy Research at La Trobe Uni, I lead their priority populations research. So we've been doing, or Scott and I have been working together for a really long time, some 15 years when I got my calculator out. And it's really since Scott completed his Master of Indigenous Health Substance Use with me and Professor Kate Conograve way back when. And then we were thinking from 2017 to last year, we were both chief investigators and on the leadership group. Scott was the joint director, I was the deputy director for the NHMRC funded Centre for Research Excellence in Indigenous Health and Alcohol. So this centre was set up to create pathways for Aboriginal and Torres Strait Islander scholars to lead the way in alcohol research. It led to 60+ scientific articles that really greatly tightened how we can work with Aboriginal and Torres Strait Islander communities to improve outcomes related to substance use. So our submission that you all have really described just some key elements from our work that is very much co-created and led with Aboriginal and Torres Strait Islander communities and health services. The team is pretty diverse, so we like that we're not just researchers. We have experts like Scott in policy and health services. We have clinicians on the team as well as community leaders. And it's really from this diverse group that we can work together to inform and support local responses. So what's going to suit in those each local pockets around substance use.
Yeah, so as Kylie sort of said, I've been working at ADAC now, or Aboriginal Drug and Alcohol Council, for well over 30 years. So I've been there from, through all the different sort of government policies over that 30-year period.
We come don't we?
which is that stop-start sort of approach, which unfortunately doesn't really help a lot of people. It might be great in the media, but on the ground. And from an organisational perspective, and why we got into research with Kylie, is that, we're one of the largest, if not the largest, drug and alcohol Indigenous service across Australia. For example, we run day centres in Ceduna, Port Augusta, that has roughly about 3,500 clients, open 7 days a week. We run residential rehabs in Adelaide and Port Augusta. We run offender rehabs in Port Augusta, outside Port Augusta Prison, and we also currently operate in all of the state prisons throughout South Australia as well. So we have a fairly good understanding of drug and alcohol and its impact on Indigenous folk. One of the things that we were lacking, though, is that whenever it came to research or things like that, we always had to go to non-Indigenous researchers. And as they were getting older and older and older and getting towards retirement sort of age, it meant that we really didn't have that capacity. So we reached out to Kylie Lee and Professor Conograve at Sydney Uni. And for example, we were able to get 8 of our staff at the time to go through to Sydney Uni and came out with a graduate diploma in Indigenous health or a master's. Most of those people still work for us today. And it was through that period that we started thinking that there needed to be a rethink in the way current efforts, for example, on screening for substance use amongst the Indigenous peoples were, and to offer subsequent care. And we lay out the reasons, which we put, I'm pretty sure, in our submission. There needs to be better measurement methods are needed that are designed for and with Aboriginal and Torres Strait Islander communities to screen for substance use, because there isn't a lot of that happening, right? Existing national survey data, such as the National Drug Strategy Household Survey, has been shown to underestimate drinking by up to 700% for Aboriginal women. With the NHMRC grant that we also got on top of the one to set up the Centre for Excellence, we also got a NHMRC grant to develop what we call the GROG app. And so basically we've got an app that we can go into a community and, before you do an intervention, we could actually survey that community. It's graphic, it's male and female orientated, it's in English and Pitjantjatjara as well. And we could work out basically how many people or what the issues are when it comes to drug, or in this case, around alcohol. You could then design your intervention. And then halfway through your intervention, you could actually do the app again, because it only takes about 10 minutes for people to do. And if nothing was actually changing, then rather than wait years later before you sort of change your intervention, you could tweak the intervention straight away. So we've got.
Can you just explain the GROG app again? This is a free app, I'm assuming.
Yeah, it's basically, it works on we were a bit silly when we first developed it, because we're Apple heads, so we thought, okay, an iPad, right? So we got it developed for an iPad. And basically, if you're sitting, let's say you're out there waiting to see your health worker or whatever, we could give you the app and some headphones. You could be sitting there doing whatever as far as anyone, but you're actually being asked a series of questions. When you go on it, like I said, it's graphic. So it'll ask you what sex you are, and then if you say you're male, then all of the imagery will turn into male-orientated imagery. If you're female, they go into female. And then it just basically asks you a whole series of questions about, how much do you drink? We don't ask about standard drinks because, as you probably know, most Australians today still don't know what a standard drink is, right? So, so what we do is we ask things like, what do you drink? And we've got nearly every picture of every alcoholic beverage you can imagine on the app. So they scroll through to find what they want.
And what container were you drinking out
of
as well? So because, not just what's on the alcohol.gov.au.
Because most people, outside of a pub and that, might be using a Mount Franklin water bottle to sort of, fill up from a cask or whatever. So they're non-standard drinking. So as soon as you select what you're drinking, also what the container, the app will automatically calculate how many standard drinks that person drinks in a given period.
Good.
And then at the end, it's going to give you tailored feedback based on your responses as well, which is, you said, Scott, that was particularly relevant the more remote you go, where there was such workforce development issues.
So we're just so we know it works, right? And it's pretty accurate. We're just in the process. We started with alcohol first because we thought that's pretty easy to work out, right? But now we're actually developed a new app called the drug app because, we can't think of more original names, I suppose. But it's sort of pretty, it tells you exactly what it is, right? Yeah. And we just started trialling that in a remote community because The app has to work for people who live in remote communities where English might be a second or third language, as well as in an urban setting, right? And so we're just trialling at the moment where we've got a range of substances like tobacco, benzodiazepines, opioid-type drugs and things like that.
And ice and
Ice or methamphetamine and stuff like that. A similar sort of idea.
Yeah.
Find out because... You know, most people don't come up and tell someone, oh, you know, I snort a couple of points of meth a day, right? They tend to keep it to themselves. The app, because you're being asked in a confidential sort of way, you'd be surprised how much people are willing to share their story because, A, you've asked them, right? But also they know that it's confidential. And so we're just trialling that at the moment. Secondly, I suppose we thought we needed a holistic approach that works with whole communities to reduce harms from alcohol. Current alcohol treatment guidelines, for example, to reduce focus on Western evidence, not on evidence from community and with cultural knowledge. So they're very westernised sort of treatment guidelines. It does not consider work conducted with a whole community, for example, or where there might be community-wide worries from alcohol. They tend to solely focus on a one-on-one intervention, and we think that there's a missed opportunity to help whole communities, along with individuals and their support people, to reflect on their drinking in a safe and culturally informed way.
I think we also we've also done quite a lot of work into bicultural models of care. So we did a systematic review a few years ago with Gemma Purcell-Cotter, who now has her PhD, a Gundungurra woman, and Gemma found a lot of bicultural models used in the States and in Canada, but there was nothing in Australia, and it really started this idea from Gemma. So we analysed some data from Aboriginal staff from community-controlled services Australia-wide. That was part of another project grant that we had, and Gemma's model is really just so unique because it really pinpoints how health professionals, whether you're Aboriginal or Torres Strait Islander or non-Aboriginal, but anyone working with Aboriginal community can work around alcohol. So she's kind of got these three levels, and the first level kind of shows how those really trusting relationships are at the heart of the care. So you actually need to spend a whole lot of time just to, I share something of myself and we have a yarn, we have a joke before we actually get to the business of, you know, how can I help you today? The second level kind of shows how Aboriginal and Torres Strait Islander culture can work alongside, say, relapse prevention medicines when you're delivering care. So you might have men's and women's groups, you might have relapse prevention medicines depending on what's happening for that individual. And that final level is more macro, showing how the service structure, so things at the service level that can help the individual deliver bicultural care or hinder. So how many Aboriginal staff are there, or is the management really, are they supportive of maybe Aboriginal clinicians doing one-on-one sessions outside as well as inside, that kind of thing?
Sure.
So, and I think it's finally, the final point we wanted to mention is about how critical it is that we continue to invest in efforts to strengthen capacity and build support for Aboriginal and Torres Strait Islander scholars. And I guess this is an area that Scott and I have done a lot in via that Centre of Research Excellence that we mentioned earlier. So we had 7 completed PhD scholars, 1 research master's, 3 trainees in research support, and 1 clinician researcher trainee, a Wiradjuri woman. And insights from this centre, you know, informed the drinking guidelines, the treatment guidelines, the New South Wales withdrawal guidance, that kind of thing. But it's also really progressed the field in terms of how we can co-create efforts to support Aboriginal and Torres Strait Islander scholars as well to survive, but also to thrive in research in terms of their contributions.
Yeah, look, I might just start the question if I can. And the committee in a previous inquiry did go to Darwin and Alice Springs a couple of times. And we were shocked by the level of alcohol abuse. In the previous inquiry into diabetes, it was mentioned as a factor compounding the complications of diabetes and health problems. Do you think the community, and I know there are many different communities around the country, but do you think the Indigenous community or First Nations community is aware of the dangers of alcohol? Do you think we need to do more in awareness?
I think you do need to do more. I don't think it's interesting. Me and Kylie just prior were talking about with the GROG app, also looking at maybe adapting that to look at things like breast cancer, because there isn't a lot of connection that people have, in particular with in an Indigenous setting, of the connection between breast cancer and alcohol. Yeah. So the chances are that a lot of people have that connection between alcohol and diabetes, for example, is probably the same. Recently, I'm talking myself, did the evaluation of the FASD component of Strongborn's campaign. They had an Indigenous one component of that as well. And it was interesting that of those communities that were given small grants to do community awareness programs around fetal alcohol and alcohol, they basically had, you know, a good uptake. For those communities who didn't get the grants, then obviously it's not an issue that they sort of really focus on. So you can sort of see that we need to sort of like, I was on the committee that came out with the alcohol guidelines that were released a couple of years ago, for example, and was a bit surprised that, you know, I would have thought that the Commonwealth, i.e. Department of Health, would have actually had a major information campaign around the alcohol guidelines, because they had changed in some of the messaging. But once it got released, there was a bit of media attention about it, and then that was it.
But not at a community level.
Yeah. So that's why I still think that most people, that whole thing about drinking whilst pregnant, or also drinking, you know, within the guidelines, hasn't really got out into remote places like Alice Springs, or even in Darwin, for example.
Yeah, a friend of mine, Elizabeth Elliott, has been talking in this space for 40 years.
Yeah, yeah.
And it just seems that we're not getting the message through.
No, well, when you see a can of, let's say, Jack Daniels or whatever, and you've got a little image about that big of a pregnant woman, you know, if you're sort of bit visually impaired, you're not actually going to see that image anyway. Whereas from my perspective, it should always be similar to a packet of cigarettes.
Yeah. And will your GROG app pick up the alcohol intake during pregnancy? You're targeting?
It does.
It does. So we ask about if they're pregnant and at what stage they're pregnant. We've got we should hear about an ideas grant that we submitted, which is actually going to help midwives and people in antenatal care screen women for their risky drinking using the GROG app. So actually specifically getting it to talk to the software that they're using to make it easier for the health professional, but also a more kind of safe and less judgmental kind of approach for the person who's pregnant and who's being asked as well. Because there's a lot of qualitative research showing that midwives often don't know what to ask, and if they do ask, they don't know what to do with that information either, because they're not AOD trained. They're trained to look after the mum and the bub.
And are health professionals being made aware of this?
Where
we can, like, we modified the app for Aboriginal folk at the Women's and Children's in Adelaide, for example, to also, they wanted to know about not just drinking and pregnancy, but they also wanted questions in there about cannabis and pregnancy. So we were able to modify the app to actually ask for them to be able to use when women are coming into antenatal classes, to actually ask not just alcohol related questions but also cannabis related. We just recently have realised that a lot of doctors, GPs for example, might not necessarily know how to broach that question with their clients either about drinking. So we've now in the process, we've had a workshop with a few of them where we're just going to have the app so it produces a graphic A4 sheet of paper, tells the client, the doctor, this is how much this client drinks on a given, be pictorial, how much they drink, whether it's within the guidelines or out of the guideline. If it takes a couple of minutes and it's only a sheet that big, then the doctor, it could prompt them to actually start asking that client about their drinking. Oh, we notice that you're drinking above the guidelines. Have you thought about X, Y, Z?
Well, this should be mandatory in antenatal clinics.
It should be.
Yes, but it's really variable. They don't tend to use systematic tools, or if they do use the tools, they don't know how to interpret the answers, like the scores. So some might use Audit C, the 3 consumption questions from the full audit, but some just ask, do you drink? It's so this qualitative research with a really good qualitative study with some midwives showed that the health professionals felt uncomfortable, and understandably the women being interviewed felt quite judged as well. Yeah. So that's why we're lucky enough to get a MRFF grant specifically in digital innovation. So we are working with government-led health services and community controls to get the GROG app to work in a GP kind of environment where you guys don't have very long. They want something that's going to be 5 minutes, and then just to make it easier for the client, so people are being systematically asked, and then the app can almost be a jumping board, because often our GP and health worker friends will say, oh, it feels like I'm getting in too close. I already need to ask about all this stuff, and then I need to ask about alcohol. So one of the questions they wanted was, are you worried about your drinking? So they don't want to know what worry. They just want to know, yes, the person's worried, and then they can say, oh, Scott, I saw that you said you were worried about your drinking. Is it okay to ask you about that? Can I talk about that? It's kind of like the app's helping to open the door.
Right. So you're running a trial.
We are in the first stages of that. So we've just we've run a Delphi study, and we've developed the concept of the app. I'm about to go in to build the technical side of it. And then we're going to test it, implement it using continuous quality improvement, and then I'll revalidate it.
Yeah, but where are you doing it, though?
Doing it in a mixture of Queensland and New South Wales for these ones. Yeah.
Can't tell me where in New South Wales, can you?
I don't have permission from the New South Wales site, actually, in terms of the ethics, but the Queensland site I do, because they're happy to be known. So the Queensland site we're doing with Anala Indigenous Health Service, which is a Queensland Health.
Sure. Yeah.
One of our chief investigators, Professor Noel Heyman, is there.
Right. Good. So I have to my colleagues some questions. Michelle, would you like to?
Yeah, look, the app sounds really exciting. I guess I have a sort of just a question, just to pull back from it. As researchers, you generate really valuable knowledge, and I guess the question I have is, how do we, as policymakers, going forward, irrespective of whichever government is in power, really harness those learnings and then disseminate that throughout the country? Because we have NHMRC, we have MRFF. There's no guarantee that the knowledge you create is going to go anywhere, right?
Yeah, that's true.
And it happens across the board in research, and yet this sort of work that you're doing is so important, right? You're actually doing implementation, co-design. You're following all those principles of best practice, particularly with this really sensitive, low-trust community. So, what do you think we need to have going forward?
I suppose, well, from my perspective, considering that, the app and that was launched by the then Health Minister Susan Ley and Ken Wyatt at Sydney Uni. Now, we would have thought that down the track, once we had the app up and, developed and all of that, somebody might have actually, from that area, might have actually asked us for a demonstration. Do you know what I mean? It seems to me that you get grants, and you're right, you go off and do all of this great work, and we tell the research sector, because we publish on what we do quite often, but the policymakers who you would think would like to don't seem to have that same interest. So us trying to get in front of, let's say the Department of Health, for example, just to give them a demonstration has been really, really difficult and problematic. Like from my perspective, maybe when the Alice Springs issues happened a year or so ago, and the federal government at the time said, okay, here's $250 million to sort of that you put into that region. Maybe if you had actually had seen the GROG app, you could have actually sent some people in there to do a survey of what the issue was. Might have saved $250 million in actually trying to work out what it was. Because for a lot of Aboriginal folk, I would suggest that we're opportunistic drinkers. So, you know, if we get caught in town, well, I run into another family member, we've got a few dollars, what else are we going to do? We'll go and get some grog, right? What we did in a remote community when people would see the Aboriginal folk always over there drinking. And don't get me wrong, when they were drinking, they're drinking out huge amounts. But it was really interesting. So we surveyed that group, and when they were there, they were drinking upwards of 18 standard drinks a day. But in actual fact, that was only for a short period of time, because a lot of the times when they went back to community, the communities they go back to are dry, so they're not drinking. So if you averaged it out, in actual fact, they were actually drinking within the standard guidelines in a given year.
But binge drinking by the sound.
But they were,
Episodic.
binge drinking, episodic and opportunistic.
I guess, so, I mean, just going back to my original question, I completely agree with what you've just said, that these, I think policymakers are interested. I think we just have crowded agendas, that's all.
I imagine.
But, you know, I'm very interested in the NICE model in the UK, which is really focused on implementation, gathering data, best practice, and, you know, I feel like there's a gap in Australia with respect to really knowledge creation, which is NHMRC, MRFF, etc., versus then the implementation and gathering best practice. I don't see a body or an entity in this country that does that, and I think given our federation and given all the other problems we have, we desperately need to have something focused on implementation. That's just an observation. My second question really refers to workforce. I think you touched upon it, the importance of workforce, and workforce that really understands the cultural sensitivities of this group. What are your thoughts on how we ramp up workforce in this space?
Well, to me, clearly, you know, like the Centre for Research Excellence clearly showed that if you actually put the time and effort into, obviously we were targeting more high-level people to get degrees.
I'm getting at more the...
You're getting down below.
We've done it from the sort of... There were groups in New South Wales that were doing the certificate level, and then there were always people that wanted to do more. And that's great in terms of, that meant that they could go higher in terms of salary as well. So we found it was targeting the grad dip and the master's level were really, you know, you had people there that were coming in, had 30 years of community experience, couldn't write a paragraph. So we were doing all of that, as well as they were upskilling us in community and cultural ways. We were upskilling them in the treatment guidelines. It worked. Kate Conogrove and I ran that, I think, from 2008 until 2014. But we actually weren't funded to do it. I was on NHMRC fellowship at the time, and Kate was employed by RPA Hospital. So that sort of course, I know, is being called out for by frontline. Like
interesting.
AOD
so
workers.
It's a bit like professional development.
Yeah.
Totally. And then from there, you're always going to get some people that want to go to do their masters, like what Scott did, or do research as
and
well.
Still retain some clinical presence.
Yeah. So we've got people who are on our team that are clinician researchers, basically. So
that's a really interesting model.
Yeah, but doing it in a way where what we've tried to do is we've been documenting the model of workforce as well as the knowledge gain and the output, and trying to increase the rigor in the alcohol field as well. So we've I can send it through to Eva later, but we have actually documented that sort of walking side by side model, because it's very different. Upskilling and training people in a really sensitive field like alcohol compared with someone getting their their bachelor in arts or a physics PhD.
Particularly when the knowledge is still evolving continuously, right?
And where most people come in having lived experience or living experience from their families or maybe themselves as well. So you really need to tread carefully and acknowledging the diversity amongst the Aboriginal and Torres Strait Islander people in Australia as well. So really respecting different nations.
If you could send us that model, that would be great. Thank you.
I can, and I was just going to say that implementation study that Scott talked about, that we're running the MRFF, that is actually an implementation study, so that's exciting that we're going to be developing the knowledge, but you're straight away implementing it.
Embedding it.
At Anala. Yeah, so they are helping us work out how to do it there, and we chose there because as you're aware, every primary care service around Australia looks different, but they just have excellent research and clinical governance there. So if we're going to do something complicated like alcohol, we figured, we'd partner with people that we'd done it with before.
Thank you.
Good. Julian, would you like to...
I wanted to ask about the GROG app and whether it picks up drug use as well, or is it just picking up alcohol?
We've got an ideas grant that is extending the GROG app to also measure tobacco, cannabis, methamphetamines, opioid-based painkillers, benzos and heroin. It also does have an other drug section as well. So we're just validating that at the moment in South Australia and in Queensland. So by next year that will be validated. So and it's kind of like, it'll be like a constellation of apps at that stage. You can still use just alcohol. Some researchers and some communities are really worried about alcohol and meth. So eventually you'll just be able to use it for 2 drugs or all drugs. You'll be able to add drugs. We've done it in a way where it's customizable as well. So if a particular community was really interested in like environmental health, and how many dogs were living in the house, and as well as alcohol, then you can add in other questions, and then you can also add in other feedback. The other great thing is that when we first designed it, as Scott said, it's got Pitjantjatjara language because we were doing a lot of work in South Australia, but the new version has actually designed so you could add in an Arabic track or a Chinese track or whatever as well. So it's designed as like a safe place for people to tell their story without sort of feeling like anyone can listen or feeling judged. And I like that it works offline. So once you've got the app on your device, if the internet cuts out, or if you're living in Ceduna or something and you don't have great internet, it'll still work and it'll still give you that tailored feedback, which is really important because a lot of people might not. I find it's really tricky to do those sorts of brief interventions with people.
And the GROG app is really for people who are looking to make change in their lives, isn't it? They've got to first decide. It's not a kind of an alcohol addiction eradication program. It's effectively a tool to help people who are on a journey that is more individualised, removes the stigma.
Or you could use it for a whole of community to find out, prevalence in that discrete community, for example.
But people have got to want to actually engage with it.
Well, we didn't really have any problem. Like when we went into one council area, 30% of the Aboriginal population within that council region, which is huge, right, actually came and had no problem doing the app. We were there for a while. So we went to shopping centres and where we knew...
Did you incentivise usage of the app?
Big pardon?
Did you incentivise the usage of the app?
When we were doing the trial, we did, yes.
What was the incentive?
$20.
Right.
Which was either a
Coles card.
Coles card, or if we were over in one of the remote communities, it was a community store voucher.
But a lot of people stopped to talk to us afterwards because they were like, oh, I didn't realise that I drank that much, or I don't drink, but this app actually makes me really worried about my auntie who does drink. So it's kind of there to help people to describe their drinking or their non-drinking, and most importantly for them to get feedback right in the moment. Because even if they go to their primary care service or local drug and alcohol service, there might not be people there who can straight away give them that sort of feedback to help them exactly where they're at.
Let me ask you a question about Indigenous communities and alcohol, just broadly. Are there particular Indigenous leaders that are, of a strong, banning alcohol bent, as it were? I mean, it's fair to say that alcohol, I think, and increasingly other drugs are destroying Indigenous culture and Indigenous communities in this country, and it has to be the community themselves that have to make the decision that they want to do something about it, and I respect that. But perhaps we don't always hear in the rest of the community those strong voices of women. I mean, I think about people like June Oscar and Marcia Langton and so on, particularly in relation to the link between domestic violence and alcohol abuse in Indigenous communities. But I mean, are there particular prominent communities or prominent people where decisions have been made that we're going to go dry, where that decision has stuck, where there's developed a culture about alcohol in the community, and how does one encourage other communities to go down that path?
The answer is yes and no. Like the answer, if you go back 70s and 80s and periods like that, there was a lot of people who, let's go down the dry zone and ban alcohol and things like that. The problem is that as those people get older and older, and unfortunately a lot of them die, then the next generation that are coming along still haven't got the education about, so they weren't there. And I've been, I grew up in Darwin, so I know most of these communities probably, because I was a full-on drinker myself, right? And so you go to these communities where there's, a lot of alcohol, a lot of violence and all of that. They might change, but then this generation of people that are sort of growing up weren't there when that community was riddled with alcohol. All of a sudden now they want to say, well, hang on, I'll give Yalata as an example, because they're a couple hundred kilometres away from Ceduna, right? So the younger folk there are probably thinking, well, I know they are, why do we have to go all the way to Ceduna? Why can't we eat? Because Yalata went dry, right? But you've got to renew the dry zones. You can't just sort of put on a dry zone for forever. And the problem is when you go back to have that community consultation about, should we continue with the dry zone? The people who might have been the real strong, they're no longer there, or they're old, or they're infirm, or whatever. And so it'd be the new generation who's saying, well, hang on, why can't we? And it takes a while before all of a sudden, they start realising, well, in actual fact, the grog that they have here is part of the problems that they have. But I can give you an example of our chairperson of the organisation I work for. He lives in Oodnadatta, which is 1,000 kilometres north of Adelaide, whatever. They actually own the pub. And do they have alcohol-related problems? Of course they do. But do they have the same problems that, let's say, they might have had in Ceduna? No, because they have a management plan in place on how they lease the pub, and then if anyone mucks up, you have to go in front of the pub committee, and and it's the only place you can, because the nearest place you're going to go is Coopiti, which is a couple hundred miles away. So there are ways that people have managed to live with alcohol. I suppose the problem for a lot of us is when we get into a big town, whether it's we're going there for whatever reason, like Ceduna had a dry zone that was a trial, and then what happened is that the local shops were selling, bottles of wine for $3. So we weren't going to the bottle shop anymore. We're going to the local, supermarket and buying cheaper alcohol than what we could. So the dry zone in that community was just lifted just recently. So
you also had the sort of cashless debit card issue that was in Ceduna as well. Just one other question: to what extent do bottle shop owners and pub owners have some social obligation that they have in relation to let me start the thought again. To what extent is the social obligation of bottle shop owners and publicans being actually enforced such that they're not selling to intoxicated people and they're not selling? When I was the Shadow Minister for Indigenous Affairs and Chair of the House Indigenous Affairs Committee, I remember seeing some, extraordinarily bad practices where people were clearly buying for themselves more alcohol than I could drink in a year.
Exactly.
Where's the obligation on the...
There doesn't seem to be a lot. I'll give you the same example is, one of the reasons why the Liquor Commission sort of said that they were going to, stop the restrictions in that one community is because the local hotel had a 30% reduction in income. And that's unfair, right? We objected to that, but at the end of the day, it is a decision of the Commission, and they upheld their original decision, even though we operate the day centre. So we see the clients who come, because we open at 7 a.m, so we see the clients in the morning who, come in with cuts and bruises and from the alcohol abuse the night before. I think that they're, part of the liquor commission sort of thing should have, social obligations on all people, who, whether they're a bottle shop or a pub. As you probably know, they brought in the responsible services for alcohol. I could go to any pub here in Melbourne tonight and there would be people getting served that clearly you wonder how they get to the bar, right?
Yeah,
but...
It's more on it in the breach, isn't it?
It is, but, people don't really enforce the regulations that are already in place. So.
Yeah. Thank you.
Monique?
Do you have ongoing concerns about sustainability of the app?
Yes and no. Obviously, we're involved. We're not sort of running away tomorrow, but obviously, if it becomes embedded in use, well, then you would have those sort of upgradability sort of agreements built into, let's say, the Department of Health, for example. That they maintain, its sort of currency as you move forward, because things will change. I'm pretty sure the alcohol guidelines in the next when they do another review, will probably might change again. So you'll have to sort of relook at that.
That's where the customizability of the app. So we've really tried to future-proof it. So you can add in, even in the opioid section, you can add in lots of other drugs, different doses. It lasts this much time in your body. Same with alcohol. You can add in new products. So you can change new languages, that kind of thing. So it's really almost like it's a full kind of customizable platform there. At a university level, we do sort of, and we do cybersecurity testing and penetration testing as well, because you can use the app in what's more like a health promotion mode, where it doesn't collect my data, or like what Scott and I are doing at the moment, it'll collect data. That's why we kind of have that sort of penetration testing as well, just to check that data, even though no names are collected, but it's kind of safe. So we've kind of designed it in a sustainable way, in the sense that we're really trying to future-proof, because there's always going to be another type of container, another type of product that's out there.
Does it provide notifications?
Not at this stage. I think it will with the primary care version, because at the moment it's really used at a community level. So community-controlled health services and community councils use it because they don't have another way to get a really clear picture of drinking in their community. And the only available data is National Drug Strategy, and it's really not, it's just not reflective of what's on the ground.
Sorry, I did mean to do that.
Yeah. And in terms of, I always worry about reliability of reporting and of data, especially, I guess, when you look at things over a period of time. Without being overly critical, how confident can you be that the data that you're collecting really reflects reality?
We've done validation studies and prevalence studies to show that it's reflective of the community that so we've actually done separate scientific studies to show the representativeness of communities compared with available Australian data. And then we're supplementing that with the fact that we've always got sort of local Aboriginal health workers that are co-authors on the paper as well. So even when we're analysed, they're helping us collect the data, but then when we're analysing the data, we're constantly kind of reflecting back and going, oh, is there another way we could be analysing this? What does it mean? So I think it really points for us that you need to be doing it at that, I mean, it's labour intensive, but at that community by community level, because we did a meta-analysis of alcohol consumption using grey as well as scientific literature. I think we published it 4 years ago. James Conagray was the lead on that. And it really showed that even within Aboriginal communities, there's just such a diversity of alcohol use, like levels of use, within and between communities, which is what really got us thinking about something like about the Grog app, because we need tools to help collect. Likewise, we've got clinician colleagues in emergency as well, kind of saying, oh, we need something like that here as well.
Okay. Thanks, Chair.
Is the app scalable for all the population? So at the moment, and the reason you developed it was about cultural synergies with Aboriginal and Torres Strait Islander, but you've said a couple of times you can stick Chinese or Arabic or whatever.
Yeah.
We've got, yes, Scott and I have an early career researcher who's an Iraqi Australian who came to Australia as a refugee, and she's actually writing a paper at the moment about how hard it is to get accurate data as well for culturally linguistically diverse peoples in Australia. So, and I was kind of talking with one of the state governments about trying to use some artificial intelligence technology to kind of help us more quickly create various language tracks. So if you wanted Cantonese or if you wanted Vietnamese, something like that. But we certainly have a range of multicultural orgs who are really interested because they recognise that similar to the Aboriginal and Torres Strait Islander setting, drinking can occur really episodically, and there can be a lot of shame around drinking as well. And our health professional friends are saying when people come into our services and they are culturally, linguistically diverse, not very comfortable with English as a first language, it's actually really hard to provide care or to provide advice, let alone screen people, because they're not sure that they're getting the message across with the barrier, which is why our Iraqi Australian kind of early career researcher is really keen to help us with that work, acknowledging that there's a multitude of different culturally linguistically diverse groups in Australia, but we're just starting to talk to some of those peak multicultural orgs, and there seems to be quite a bit of interest.
With time and research opportunities, do you think that this app could be provided to all GPs? In a situation where there's a new patient, for instance.
Yeah.
And would you think that it would be relevant for other things that needed to be screened as well? Because, the thing that you hear all the time is there's not enough GPs and they don't have enough time with patients. So, would you envisage in the future that this would provide the necessary talking points in a time-poor consultation that would mean that there would be some satisfaction that GPs are actually getting the answers to the question they need to go forward instead of having to have 4 or 5 consultations to get there? Do you see a place for that?
I do. The whole idea was that, while you're sitting in there waiting to see the doctor, usually, let's be honest, they're never on time.
No.
So you do have the time to sort of, do the app because I can do it I know it fairly well. It only takes a couple of minutes, right, to go through the whole thing. And it can actually then give the GP or your the
Health
nurse,
worker,
whoever,
yeah.
an actual snapshot of your consumption pattern and stuff like that. And because it's pictorial, they don't have to read a lot. It's right in your face, right?
Which is why it's good for cold as well.
Yeah.
And I really like the idea that you can normalise asking about something that the health professional finds uncomfortable to ask sometimes, and the person receiving the questions
Doesn't
finds
want to
uncomfortable as well. I liken it as, you know, every year I get my vitamin D checks with my GP and all the rest of it, and it's like every year they might ask me to do the grog app. It's just, it should be, I think we'd be able to pick up things way faster. Some health workers also want to kind of add in chronic disease questions in there as well. We've got a MRFF grant being assessed at the moment to add in mental health, acknowledging that, you know, they're so closely linked. And I must admit that 2 of our Aboriginal research support people are so excited about that mental health grant, even though I said it's not a sure thing, because it's, for once, we're not just looking at one issue, we're kind of broadening it out, acknowledging that alcohol exists.
Have you got proof of concept from the GPs or nurse practitioners or psychologists or whomever about that development? Like, have you showed it to other people?
Yeah, we have, because that's funded, that one at the moment. So that's a funded MRFF in the primary care and digital innovation, one of their streams. So yeah, I've got the whole proof of what it's going to look like. It's just that then it's going to be tweaked, because as we said before, it's an implementation study. So we want to just check that it's actually going to not be onerous and not burdensome, and not be too hard on the staff at the, you know, the triage, the front desk and that kind of thing as well. So, and then it's going to have to fit. Every GP practice is different.
Thank you.
Conscious.
Yeah, thank you.
Thank you so much for coming today. And thank you for the evidence you've been given. If you've been asked to provide any additional information, could you please forward it to the Secretariat by no later than Tuesday the 12th of November 2024. You'll be sent a transcript of your evidence, and we'll have an opportunity to request any corrections to transcription errors. Once again, thanks for coming. It's been really important evidence.
No worries, thanks for your time.
I'd now like to call the Australian College for Emergency Medicine to give evidence today. Thank you. I now welcome Professor Diana Edgerton-Warburton from the College of Emergency Medicine to give evidence today. For the Hansard record, would you please state your name and the capacity in which you appear before the committee before giving evidence? This hearing is a legal proceeding of the Parliament. The giving of false and misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to give evidence. Thank you.
Thank you. My name is Diana Edgerton-Warburton. I'm an emergency physician at Monash Health and fellow of the Australasian College for Emergency Medicine. I'm also a professor of emergency care research at Monash University. I'm giving capacity as a fellow of the College of Emergency Medicine.
Thank you. Would you like to proceed to an opening statement?
Yes, thank you. I've led our college's alcohol harm project for over a decade and published more than a dozen papers on alcohol and other drug harm in the community and the EDs. I was also a member of ANACAD, the Australian National Advisory Council on Drugs and Alcohol, to the Health Minister. I appreciate the opportunity to talk today, and I'm looking forward to sharing some experiences. ASEM is a not-for-profit organisation tasked with training specialist emergency physicians and maintaining professional standards in emergency medicine in Australia and New Zealand. I speak on behalf of emergency physicians, trainees, our consumers and our community that attend EDs across the country. The insights that I'm going to give today are in part my own experience, in part experience from my research, and also particularly surveys of emergency physicians and their experience. Our membership has identified alcohol harm and other drugs as a research and advocacy priority. This is not just because of the sheer volume of presentations to the emergency department, but also the impact on our patients, the functioning of the ED, staff wellness and retention, and occupational violence and aggression related to alcohol harm is an everyday occurrence in emergency departments. It's not a problem on the weekends, it's every day of the week. Our research indicates that around 10% of ED presentations are alcohol related, having completed the biggest international study of alcohol harm in the emergency department. That's 10% of ED attendances which are entirely preventable and create a burden beyond the actual number of presentations. It's not just the people presenting with alcohol harm, but also alcohol harms to other people that present, and that then flows on to harm to the emergency department. Other drugs, particularly the one I've looked into the most, is amphetamine-type stimulants, which represent about 1% of attendances, but also have a disproportional amount of harm. As I said, it's an everyday problem, and we performed a survey in 2016 and repeated the survey several years ago, and it demonstrated that 95% of emergency physicians and clinicians, nurses and other workers experience violence, alcohol-related violence and threats of violence, with 9 out of 10 having threats of physical violence or physical violence itself. And 2/3 of those report this to be a daily or weekly occurrence. Our recent survey demonstrates, while the numbers remained as equally bad, 2/3 of clinicians felt the problem was getting worse in emergency departments. I just want to quote directly from some of the respondents I got from the survey. This is an ED nurse. I was obviously pregnant. An alcohol-affected patient threatened to punch me in the stomach in front of his wife and kids. A doctor. I was assaulted, knocked unconscious by an intoxicated patient. Later, he was asked why he did it, and he said that no one bought him a sandwich. A consumer. I attended the ED at 2 a.m. with my 3-year-old daughter, concerned about her breathing. The ED waiting room was such a dangerous environment with alcohol-affected patients that I left despite being concerned about her well-being. A doctor. You only need one alcohol-affected patient to completely disrupt the function of the ED, and this is particularly in rural and regional situations. If a patient is dying or in pain, the last thing they need is a yelling, abusive and swearing patient next door. I've been verbally threatened, physically assaulted, pushed, punched, spat on and bitten. ASIM has included a series of recommendations in our written submission to the inquiry, but I'd like to highlight 2 for particular attention, which I think the Commonwealth has real opportunity. Clearly, policy change is going to be the most effective lever, and while illicit drugs are challenging in terms of this and require a harm minimise and multidisciplinary approach, policymakers have direct and effective levers to reduce alcohol harm and therefore presenting to the ED. These obviously include pricing, advertising, particularly in sport when it's directed at children and young people, and also availability. I talk about the reverse Jesus Christ phenomena. You know, people wanted to celebrate. Jesus came and turned water into wine so people could celebrate. We're now in a situation that we have the cheapest alcohol available in Australia, such that now it can be more expensive to buy a bottle of water than to actually buy wine. Our taxation system has been described as illogical. And I'd particularly like to highlight the wine equalisation tax as an issue, which results in wine being able to be sold based upon the wholesale price rather than the volume of alcohol. 65% of wine sales is under less than $8 for a bottle of wine. That equates to around 24 cents a standard drink for wine. While the minimum unit pricing is an issue that can also have a lever of this, that's obviously a state jurisdictional issue. Quite often in the emergency department, or almost always, I ask people about their drinking habit, and it's that group of really problematic drinkers who are most affected by that price point. And sometimes when I ask the problem drinker, how much do you drink a day? I get the response quite commonly, as much as I can afford to buy. And it's this group that target the really cheap alcohol and where we see the disproportionate amount of harm. So the average, person on the pub test of going to buy, a middy of beer, either obviously that's not a wine equalisation, but a minimum unit price that we agreed as a community, we would resolve this issue, set at $1.30 for a standard drink. I also had the experience of my son who just, was just able to start buying alcohol, and he came home with milk-based cruisers that were on sale at a wine store. And I was like, I didn't know you liked those. He's like, yeah, they were out of date, so they were selling them on special at the... So the other key area where I think you can help with is data. Now, this is not something that the Commonwealth has asked us, but the College for Emergency Medicine has had a policy on including alcohol and drug elements in the the national minimum data set for non-admitted patients. It would provide incredibly powerful both evidence of harm and harm to others, but also provide, when you push those policy levers, being able to measure the impact. The wastewater information is important around illicit drugs, but if people are using things in their own home and pissing them down the toilet, then that's having less impact than if they're tending up in emergency departments or with police with harm. So these processes, I've also been involved in a research program with Professor Peter Miller called Driving Change, which uses data from EDs and also develops local drug and alcohol action groups. They share data. And about a large proportion of cases that are serious enough assaults, alcohol and drug-related assaults that attend emergency departments, a large proportion of them unknown to the police. And by sharing data, we can identify, for example, problem venues and have dedicated licensing approaches to reduce alcohol harm. And this was developed, the Cardiff model it's called. It's developed by, I'm just going to have to take the name of the person who developed it in Cardiff, but we've worked together on a similar project in Australia. And I remember going to Warrnambool and hearing this police officer tell me about the project he's involved in, the Driving Change project, to sharing data with academics and doctors and local councils. And he said to me, I just got my sergeant to pull out the last 100 cases of assaults in Warrnambool. And he said 99% of them involved alcohol harm. And he said to me, this guy was about 7 foot and about 3 foot wide, and he said to me, I've been, in policing in Warrnambool for 30 years, and he said, this is the most valuable thing I've done in my whole career, being involved in these projects to come up with local solutions to reduce alcohol harm. So emergency clinicians, they want to work with policymakers to make real change, and we can do that by increasing the price and collecting national data. Thank you.
Thank you very much. Julian, would you like to?
Yes, I'm particularly interested in the violence in ED and security in ED. I served on a hospital board in a major hospital here in Victoria before I was an MP, and we saw even, that's more than 8 years ago, that this was a huge problem there. What can policymakers do to improve the security in EDs, particularly from violent patients, particularly around episodes where they're coming off methamphetamines and so on?
When you look at the hierarchy of risk, right at the very top of it is elimination. And so what policymakers can do in the most powerful way is to reduce the price of alcohol, increase the price of alcohol. And but then, because the challenge is that the people that attend emergency departments have real medical issues and are very high risk in terms of their presentations. And so when you look at those sort of personal protective measures, they're at the very base of the triangle in terms of effectiveness and the highest cost in terms of processes, but also really challenging to be effective, because it's really hard to have a security guard in front of every swing punch that is swung. But I think the process that's been very helpful for the last is the multidisciplinary teams and the dedicated areas in emergency departments to be able to manage these people. I was asked at one Commonwealth round table about reducing harm from injury from alcohol and occupational violence, and they said, well, what's changed in the last year? Because I was in the 1990s working at Footscray Hospital, and when we used to have violent and aggressive patients that were drug affected and alcohol affected, we used to call the police and they would take them away. Obviously, we don't want to go back to that because, alcohol intoxication and addiction are medical problems and they need careful observations. But what's happened is they've come into the emergency department and we don't have the physically safe environment to manage these people. So mental health and drug and alcohol hubs where we can have low stimulus environments, and I know those processes are funded by state governments and have been shown to be both consumer-centred and also reduce violence and aggression towards clinicians.
I'm interested in your view about the pricing too of alcohol. I mean, everybody's talking about the cost of everything at the moment, given the inflation that we're seeing across the country. I ordered a schooner of beer at my local pub the other night, and I felt like a dinosaur remarking to somebody that I remembered when it was $2.60 when I was 18 having a schooner of beer. But it's now sort of, well in excess of $5, $8, $9, something like that, which just seems a ridiculous price to me. But it also seems ridiculous to me that people are paying 27 cents for alcohol. Well, I mean, given, with relation to other drugs, like tobacco, you put the price up, still people smoke. How should we base a floor price if we were going to go down that route? I'm not favouring it, but I'm just interested in testing your view about that. How should we find a floor price? What's the sort of principled way to do that?
Well, I think that addressing the wine equalisation tax, which is just a perverse, bizarre tax, would go some way to doing that. But as far as I'm aware, in terms of the governance and policy things, it's obviously not my expertise, but as far as I'm aware, it's a state-based process in terms of a minimum unit price. And the advantage of that is it can't be seen as politically unpopular because it's not a tax that the government is then collecting. But as I said, it is the really powerful driver for that small proportion of the population that uses alcohol particularly problematically, which is overrepresented in the emergency department, particularly teenagers and people with alcohol dependency. So, as you rightfully point out, it won't affect the cost of anyone who spends more than $8 on a bottle of wine or buys a schooner of beer from a pub. So that's the advantage in that it won't be seen as effect on inflation or cost of living.
So industry would strongly oppose it, I'm sure they would.
Oh, it's really interesting because I've actually spent quite a bit of time talking to the National Hotels Association, and I'm obviously not speaking for them today, but in some respects, venue owners, they want the same thing emergency physicians want. They want people to be able to enjoy alcohol in moderation and not, create an unsafe environment for their workers or processors. So, and also there's a lot of elements of industry that the wine equalisation tax, particularly anyone that sells wine for more than $8 a bottle. So there's quite a large amount of the Australian wine industry that would support these processes. So I think we have a lot of, I've experienced a lot of stakeholders to be supportive of reducing. How I always like to say, emergency physicians are not wowsers.
No, well, they're not. But look, I don't want to interrupt. I just do take a bit of issue with your statement about the venue owners' support for legislation. I mean, I can go to any pub in my neighbourhood and see the vomit stains on the footpath that demonstrate to me no one is taking any notice of responsible service of alcohol laws.
Yeah, well, this was the brilliance of the Driving Change project. Because once again, many licensed venues are being appropriate, and but there are bad apples. And the Driving Change project was looking at coming up with community-based local solutions for the problems. Sure. So just for example, in Cardiff, there was one area that there was 3 or 4 licensed venues. There was a narrow roadway, and there were a number of serious assaults and injuries, and also drunk people falling in front of cars. They couldn't identify one venue that was causing the problem, and they came up with the solution of the council coming in at 10 p.m. and putting bollards at the end of the street. So therefore, there were no cars. There was more room for the punters, so there's less assaults. And therefore, and no cars to fall in front of, so that reduced harm. And things like, removing glass from venues that have glass things. And so and with the Driving Change project as well, we shared stories with licensees, de-identified photographs of actual harm that had come from their venue, and that sharing of stories and data was very powerful in changing behaviour. And if that doesn't work, then the police come in and do an intensive licensing process, and then people lose their licence. But at the moment, as I say, there's a large proportion of these serious assaults and injuries that are happening in venues that police don't know about. This was a funded project.
I wanted just to go back one more question about the emergency departments.
Yes.
What are you seeing by way of people leaving emergency departments as a result of the violence? Can you give us any information about that?
Yes, I don't have any. We do know that people that are affected by drugs and alcohol are highly represented in terms of the did not wait to be seen.
Sorry, no, I meant
then-
medical practitioners leaving.
Yeah.
And,
Yes,
and
yeah.
health practitioners as well.
Absolutely. Well, our survey demonstrated that it had direct impacts on wellness, which we know affects retention and recruitment of staff. And I think that, both the quantitative questions we asked about that and the qualitative responses we got demonstrated that it's a key concern around the violence and aggression, and also just the impact of.
So you are having doctors and nurses and other health professionals leaving emergency departments as a result of the violence. Is that correct?
Yes.
Thank you.
Could you send us that survey? Is that
Yes, we
public
can. We
record?
can send both surveys. And I was going to say, in terms of the actual numbers, I haven't got them on the top of my head, but I can take that question on notice.
Great, that would be excellent. Thank you. Ms Stanley.
I haven't got anything. But thank you for coming today.
Okay. Just a question around inpatient detox. We've heard a lot of discussion today from various community groups who have residential detox care. However, they don't have the resourcing for the level of acuity that some of these patients require. And I just wondered, that hospitals are well resourced to a large extent in caring for these patients. They have security, diagnostics, you name it, they've got it. What are your thoughts on the Commonwealth funding additional beds in major public hospitals for detox, or at least having maybe a wing built or something co-located near public hospitals where the support from the public hospital can be given to the detox facility to help manage these higher end patients?
Yeah, look, I can't answer that question, obviously, from any of my research, and I'm not directly involved, apart from briefly in our short stay units. But I think that potentially a shared care model in terms of 24 hours in a short stay unit to particularly with alcohol harm, but other drugs need much longer periods of detox. So I think that funding of detox beds would be extremely helpful in terms of reducing harm for the most vulnerable in the population.
Do you just on that note, then, do you ever see any time in the future, if we have the right model, where the police could take these patients to one of these facilities rather than bringing them to the emergency department, or do you think that would always need to happen? Or could they come to ED, have a rapid review, and then be shunted off somewhere else?
Yeah, I think that the options are very limited for people that attend emergency departments and requesting detox, and if medical detox is required. So I think a multidisciplinary approach would be helpful.
Okay, thank you.
Good. And I've just got a few questions, and I still spend a bit of time in emergency departments, but one of the issues that we have in our emergency department, not just alcohol, but is amphetamines, quite frighteningly. And you've done, I know, some research in that thing. Is this having a major effect around the country?
It's our research suggests that there are regional hotspots for methamphetamine use, and we roughly look at, for one patient that presents with methamphetamine issues, there will be 10 people presenting with alcohol harm issues. But those patients can and do have a disproportionate effect on the functioning of the ED, and in rural EDs they can literally take up the whole police force, as well as, because they have lack of security in the hospitals, as well as the staff in the urgent care centres or in the emergency departments. So it's a huge impact, and I think that that I haven't done any quantitative research in it the last couple of years, so I don't know what trends, whether things are going increasing or decreasing, but I do know where there are emergency departments where it represents much higher proportions and a very big impact.
Right. And in terms of other drugs, have you found things like the naloxone rollout effective? Are your members noticing less deaths because of opiate overdose, or any trends of new drugs coming?
Yeah, I think that, you know, obviously fentanyl, and we've seen, we have in our briefing paper as well around early warning systems for illicit drugs, and there is a project around collecting blood samples on people that present with illicit drugs to try and pick up those processes. And I've also been involved with the pill testing processes around music festivals and those sort of things. So I think we need a sort of multi-pronged approach, including the wastewater process to best determine those. But I did do a multi-factorial analysis around determining what was the most harmful drug in terms of in Australia, and we looked, we had emergency physicians and people from the drug and alcohol sector and consumers, and a broad cross-section of communities, and I mean, clearly the standout most dangerous drug is alcohol, and I suppose that's the thing we have the most policy levers and being ability to impact, especially at that elimination and prevention big chunk at the top of the pie. You know, I describe the policy levers as just being able to turn off and on the tap, which is the misery of alcohol harm. Obviously, we need to address other drugs as well, but
far and away alcohol is the... Yeah, good. Thank you. Monique?
Thank you, Chair. Thank you. So you're with Monash Health. So your emergency department where you're working, are you seeing children as well?
Yes, we see. We have paediatric. Yeah.
Has the demographics of the patients that you're seeing who are affected by alcohol and drugs changed over time?
I think that I can only answer that from an anecdotal point of view, and I work specifically in the adult emergency department, but we, you know, we've definitely had an increase in that really heavy use of alcohol by teenagers, and they are entirely impacted by price in terms of that group. What I think the secondary supply laws in Victoria have made a big impact. And are you familiar with what I'm talking about there?
No.
So, I'd have to take on notice what year they were introduced, but it basically makes it illegal for an adult to provide alcohol to a child without their parents' permission. And so I think that has really impacted, you know, without having any quantitative data, just my anecdotal experience in terms of those teenagers who come in heavily intoxicated.
Okay. And taking into account, you've commented a couple of times that by far the biggest issue is alcohol. Would you say that comorbidities or that the stronger, more, I guess, activating agents like methamphetamines and the like have more of an issue in individuals or not?
Look, I think that the whole sort of idea that someone with methamphetamines becomes sort of superhuman and has, you know, a greater proportion of impact is the same thing happens with disinhibited people with alcohol harm. But the problems of alcohol, I describe it as like the syphilis of ingestions, because it really affects every system. People will be familiar that it's involved with 8 forms of cancer, and so the actual burden on the whole community has been well documented in research studies. So there are individuals which are terribly affected by alcohol and also terribly affected by methamphetamine and other stimulus use. I don't see them as being, it's just more of the people with alcohol.
Thank you. And I suppose just one more question. So we've talked about the impact on healthcare professionals, and obviously it's well known that people like AMBOs and the like are very much at risk. Would you say that you would be able to, that the data that you have on staff members leaving because of these exposures is accurate, or would you have any concerns about it?
Well, what I am aware of is our research around its effect on wellness. And we know that wellness then directly leads. We didn't ask a specific question from my memory about whether that's then made you leave, but then that research is clear that burnout and wellness makes you leave. So it's putting the two together. Sure. I haven't asked direct questions on that, but
I guess the point I'm trying to make is, would it be reasonable to say that your data might underestimate the size of the problem, given that we don't specifically ask when people exit the healthcare system about their reasons for doing so?
Yes, I think so.
Thank you.
Good. Well, thank you very much. We've now come to time, and thank you very much for your very thoughtful and interesting evidence, and thank you for giving us your time today. If you've been asked to provide any additional information, could you please forward it to the Secretariat by no later than Tuesday the 12th of November 2024. You'll be sent a transcript of your evidence and will have an opportunity to request any corrections to transcription errors. And once again, I think that we would all agree our emergency physicians are facing the brunt of all the problems that drug and or alcohol and other drugs are causing our health system. And please convey to your members that we appreciate what they do.
Thank you.
I'd like to thank committee members and witnesses for their time today, and I'd like to declare this public hearing today closed. Thank you.